Scheiße, wo ist das Zeug? Schatzi. Scheiße, ich sehe. Aha, da, so. Oh, ist gut, ist gut. Alles gut.
We're not live now, Khalid, isn't it?
Good morning, good afternoon, good evening. Dear speakers, dear moderators, dear members of the expert panel, dear attendees. My name is Sylvain Gaillard. I'm the head of corporate medical marketing of SIGVARIS Group. As such, it's a great pleasure for me to welcome you in the name of SIGVARIS Group to this first MOH, the Medical Online Hub webinar with the topic COVID-19 and thrombosis. The MOH is SIGVARIS Group's commitment to facilitating and supporting the medical community, and we are already planning further relevant elements of this platform in the future. I would like to thank especially the speakers and expert panel members that agreed spontaneously to participate in this event, and by doing so, made it possible to set up this MOH webinar in such a short time. Thank you all for your interest in this MOH event. I wish you all a great MOH webinar with very interesting high-class presentations and discussions. With this, I would like to hand over to Professor Sergio Giannesini for the introduction of the speakers and topics. Sergio, the scene is yours.
Thank you all, and thank you also SIGVARIS for this very outstanding initiative that is dealing with a topic that is of great interest, because thanks also to the contribution of the same Professor Caprini that we have the honor of having with us today, we know that thrombosis is a leading cause of preventable death. But in particular in these days, we know also that related to COVID, thrombosis is a leading interest worldwide. So I think this will bring interest to all the world around today. So you actually gave me a very difficult task, because introducing Professor Caprini and all his curriculum is like introducing the singing operas and all successes of Luciano Pavarotti. So I don't know where to start with that, and I will simply suggest, I don't think there is somebody who doesn't know him, but everybody can see the outstanding achievements of Professor Caprini. Many had the opportunity to meet him personally, and the few ones who didn't have to do that, I really suggested to do that, because it's really a human experience. And having somebody like him steering us over here today is a very special occasion. So I will simply remember that Professor Caprini is, of course, from the University of Chicago. We know his achievements inside the American Venous Forum and SBS, and of course, everybody knows the score that brings his own name. I just remind you what he taught us: never kill a friend, never treat a stranger. That's coming from him and from a friend of his. A sentence that is reminding us the importance of knowing the risk factors, for which we will all enjoy so much at this moment, and the wonderful humble attitude he has with all of us around the world whenever we are meeting him. You can be as big as him, but it's difficult to be as humble and nice as he is. Thank you so much. So should we go with Professor Caprini?
Can you open your mic, Professor Caprini? Yes. We can see your slides, but if you can unmute your mic, that's it. Brilliant.
Good morning, everyone. It's a great honor to be here, and I don't deserve that wonderful introduction by Sergio, but humbly accepted. I would say that it's a great honor, and I learn from all of you all the time, and I can't say how thrilled I am to be part of this group and to interact with you. I'm sure we will learn a lot together today. These are my disclosures. And now I know everyone is shocked that I would start with the Caprini score, but let me tell you why. First of all, we know the importance of thrombosis risk factors to determine the incidence of venous thromboembolism in patients. But this disease is superimposed on everything we know. And so all of the problems and the risk factors and so forth that are present in patients, their baggage, as I call it, those unique things that make each person different, we add to that and compound it with the Caprini score. So let's talk about that for a minute. I believe very firmly that one of the still missing elements in the COVID-19 pandemic analysis is not using individual risk assessment. Now, that's not to say that you need to use the Caprini score. There are many roads to Rome. And as a matter of fact, we'll talk about that later. One of the beautiful things in medical patients is with Alex Parafoulos's improved score. And he has very good data for that. It becomes even more important in this disease. But we use the Caprini score because it's so widely used in a lot of hospitals and because it's very difficult to teach a hospital more than one score. It's taken many years for my own hospital to start using the score. That having been said, we know it's a thorough history and physical. And as we said, you would never treat a stranger, so you have to find out as much about that stranger as you possibly can so that now they become like your friend. And of course, you would never hurt a friend. As the number of risk factors increases, the incidence of thrombosis goes up. As the power of each risk factor is present, that predicts the relative rate or incidence of venous thrombosis. Putting those together and combining them statistically, we come up with a simple number that's been validated in 5 million patients around the world. And that shows that as the incidence goes up of DVT, there's a nonlinear increase in the score. Now, capturing all four elements in the score is a time-consuming experience. And one of the negative things about this has been that people say, we've got this emergency, we have this pandemic, how can we sit around and ask this patient all these questions? Well, the collection is facilitated by having the patient complete a preliminary patient-friendly form in advance of elective surgery, and ideally with the help of family members. And patients that get sick, their families can help you fill this out. And the physician and other healthcare providers responsible for the admitting history and physical can then review the initial document. And here we have, the document now is in a number of languages, at least this many that I've been able to find. And it's a simple, patient-friendly, validated score that we've tested out, and it works very, very well. And so, the other thing that people forget about is you can't score a patient. I had a recent case where the patient was scored on admission that was low, but the patient got a perforation, had to be reoperated, got a pneumonia, needed a central line, IV antibiotics. Nobody paid any attention to adding those up. So the patient remained on the chart as low risk. And you have to remember that this is a dynamic score, and often the updated score will result in a change of the thrombosis prophylaxis, including the post-discharge anticoagulant prophylaxis. Now, what's really important is the completing this score, both initially. Now, why would you say that that's important? Well, if you take a person that has excessive weight, congestive heart failure, history of thrombosis, past history of cancer, the sleep apnea, cardiovascular myopathy, secondary to valvular abnormalities from hypertensive changes may be associated with the weight. that means that patient, when that patient gets the virus, that patient is automatically at very, very high risk. And in our opinion, that patient should automatically get at least double the prophylaxis you would ordinarily give the patient. Now, we assign the score of 2 additional points for the diagnosis, another point if they're symptomatic, and then 3 more points if they have a positive D-dimer. Then you have to add all of these risks of the patient to the surgical procedure risks, and of course update it during hospitalization. As I said, there's 5 million patients where it's been validated. Now you can go through the on the internet and find about 20 publications that says it doesn't work. And that's usually because of 3 reasons. Number 1, not collecting the data. Number 2, not analyzing the data properly. Or number 3, the concerns may be valid because there's certain operative procedures that may need to be scored much higher than the routine. And, but we also would like to point out that this really can be done. In Vietnam, they screened almost 3 million patients over a 2-year period and did that very successfully. I want to talk a little bit about anesthesia because we forget about that. We know about Virchow's triad, venous stasis, vascular injury, and hypercoagulability. So when the patient goes to sleep, there's venous stasis due to the calf muscle paralysis in order to intubate the patient. Venous overdistension can result. That can cause the lining of the blood vessels to crack, and that is exacerbated by the patient's own hypercoagulability, whatever they bring to the table. And then the tissues are still metabolizing, and those metabolites are sitting in that soup, in those dilated, cracked leg veins, and it increases over time. And that's why I emphasize to everyone, there's a trend today away from intermittent pneumatic compression. That's a terrible mistake. It's incredibly important in these patients. Here's a micrograph of the dilated vein during an experiment in surgery in animals, and it shows the cracks in the endothelium as the vein expands and overdistends. And the blood clots form in these collagen parts. The other thing is white cells change into adhesion molecules. As the blood flow slows, that causes the change. Those adhesion molecules actually adhere to the endothelium, and they penetrate the endothelium, damaging it. Other white cells turn into adhesion molecules and pile up on it. So this irreversibly damages the capillary interchange, which is that, as you know, the interchange between oxygen and the nutrients. So one must remember not to look at the procedure alone. A minor procedure may be in somebody with a lot of baggage. You must use pneumatic compression devices to help minimize those changes. And always remember, you don't want to ever have a straight leg. It should be slightly bent, because if it's straight, what happens is that it can obstruct the popliteal vein, the popliteal entrapment syndrome in some patients, and that further aggravates these changes. And to emphasize again, the mechanical methods of prophylaxis are a crucial component of all hospitalized patients, mandatory during surgical procedures, and there's enhanced thrombosis prophylaxis when it's combined with low molecular weight heparin. And one of our panelists from Russia has done a wonderful job in discussing this and showing the importance of these combined modalities. The off-quoted article from the New England Journal, unfortunately, has many pitfalls regarding combination therapy, and I would refer you to we've written a rebuttal to that with Stephen Kakos, and more work needs to be done. We also need to start talking about home compression, because many of these patients go home with problems, and they still require prophylaxis. So what do we know so far? We can have these patients can present as mild flu-like symptoms, serious infection leading to death, pneumonia, respiratory failure, deep vein thrombosis in the arms or legs, pulmonary emboli, pulmonary thrombosis. I didn't write that on this slide. We now realize pulmonary thrombosis is an important component, arterial thrombosis, and stroke and death. And the presence of additional risk factors compounds this. There were some, as we know, this started in Wuhan, China, and coagulation tests. The Tang article is a very often quoted article, and the mortality was 11.5%, and coagulation tests were higher. then testing the survivors on admission using D-dimer, FDP, fibrinogen levels, and PT and PTT. Now, disseminated intravascular coagulation-like syndrome was seen when it was seen, there was a very high incidence of death compared to those without it. And the sepsis from the viral infection may lead to the activation of the tangled hemostatic web. We're going to talk about that in a minute. The authors concluded that D-dimer and fibrin split product levels had an importance. Now, in COVID-19, the virus-induced inflammation triggers a cytokine storm, causing tissue factor release, thrombin generation, fibrin formation to coat the virus and prevent the spread. What a clever mechanism of the body. Unfortunate side effect is thrombosis, and the thrombosis can occur anywhere there's an endothelium. It's an attack on the endothelium throughout the body, particularly in the lungs. And that's a particularly sensitive picture here, and that's where it's very important, because that's where the alveolar capillary interface occurs, and all the oxygen and nutrients have to exchange there to keep the person alive, and it's preferentially attacked. Now, I'd like to talk about Oscar Ratnoff, a famous hematologist, his father was a pediatrician, and when he was born, he was very weak and little, and the doctor told his father to let him die, but he kept him warm with bottles. And later, Oscar Ratnoff went ahead and became very, very famous. He was very instrumental in creating the clotting cascade with Davies. He also studied his patient John Hageman and discovered factor 12 inhibition. And I'd like to read a quote from him. I'm going to limit my attention to the emerging conception that the various defenses of the body against injury are intimately interwoven. As hematologists, we may focus upon localized thrombosis, as immunologists upon complement-mediated cell damage, and so on. The body seems unable to make such clear distinctions among its defense mechanisms. However, the distinctions are man-made, and the devices through which we defend ourselves are overlapping and interlocked. As someone who has spent most of his life studying the way blood clots, perhaps I may be forgiven starting with this process. Now, what he showed, and he actually quoted 4 experiments from before the turn of the 20th century that shows through the activation of the contact activating pathway, plasma coagulation factors 12 and 11, platelet activation occurs, causing platelet plugs, coagulation, of course, with fibrin generation, fibrinolysis, of course, to negate the thrombosis, but also inflammation, induced elaboration of interleukin-1 by human monocytes, bradykinin, the kinin system is activated, the complement system is activated. Up until this time, it wasn't really recognized that the complement and kallikrein systems could be activated unless there was an antigen-antibody reaction. And this showed that factor 12 was very, very important. His theory of it was very, very important in this process. And here we see a very complicated slide that's just designed to show you the interrelationship of all of these things that are all going on at one time. And I know now we're focusing on thrombosis because that's a big clinical symptom that we see in this disease, but it's, as you realize now, much more than that. And I would just like to take a minute and talk about what we know about factor 12. And this is in ARDS. It's life-threatening due to the onset of lung edema, hypoxemia, and loss of pulmonary compliance, and most importantly, impaired gas exchange. Sepsis triggers activation of the inflammatory response mediated through the tangled hemostatic web that starts with the activation of factor 12 that triggers kallikrein and complement, and that causes increased vasodilatation, increased vascular permeability, protein leakage, lung edema, and vasodilatation that occurs that can result in ventilation perfusion mismatch. Factor 12 inhibition may offer a novel and promising approach to antagonize some of these effects. But you know what that lung looks like in the ground glass appearance and the destruction of these elements between the alveolar vascular interface. And here is a an interesting study that shows that patients who don't survive the ARDS have a much higher level of circulating factor 12. And this is the cartoon that shows where these interactions occur and how incredibly important they are and what a target that is for this disease. Now, just as an aside, arcuzumab is now being tested. It's a monoclonal immunoglobulin antibody that inhibits factor 11 from activating the clotting cascade. The drug has shown promising results as thromboprophylaxis in orthopedic surgery compared to low molecular weight heparin. And I just throw that out because that may be, we're going to need a very extensive cocktail to reverse the tangled hemostatic web. But this may be one component of the cocktail. And in patients who are prone to bleeding, although bleeding isn't a significant part of this disease, the pulmonary hemorrhages are occurring, and perhaps this might even be better than low molecular weight heparin, but that's another story. We'll talk about that because heparin has a lot of desirable effects against the tangled hemostatic web. Now, these were some recommendations that were put out using for the virus, their international guidelines, and again, recommending you really need to score your patients. Not one shoe fits all sizes. And the use of low molecular weight heparin is very important. Mechanical compression devices are very important. And remembering that, and we know this now, that all novel coronavirus patients should receive anticoagulant prophylaxis. We also need to protect the pregnant patients, and I'm surprised at the weakness of some of the guidelines that are referring to evidence-based literature. This is a whole new ballgame. We can't use evidence-based literature alone because remember, most of the clinical trials used to develop the guidelines, the CHEST guidelines, the ASH guidelines. They're based on average risk patients because you can't put high-risk patients into a control group. Here we're dealing with a gigantic number of high-risk patients. So we're going to have to improvise, we're going to have to collect data as we go along. And also we remember that the condition of some patients changes rapidly and the risk of outbreak of VTE during treatment is common. It's a dynamic change all around. And I would say that if I found out that I got this virus, I might immediately, early and adequate anticoagulation, anti-inflammatory drugs, perhaps even steroids, a variety of agents. The earlier and the earlier these are, the more effective. Now let's stop and look a minute here at the non-anticoagulant effects of heparin and related agents. Look at all these different effects. I don't have time to read them, but you have the slides. And anybody that wants this, of course, you just come to venusdisease.com. You can have anything that I have. I'm more than anxious to share it with everybody as we go along. And I'd now like to talk about what we put together from the American Venous Forum. And we did this and have published this as a beginning guideline. And now this is several weeks old, so things are changing, but at least this gets us started. All patients should receive heparin or low molecular weight heparin. We need to use a risk assessment. If you don't like that, for example, I want to point out the Padua score has been very, very successful. The improved plus D-dimer score, incredibly successful. The British have come up with a beautiful score that has actually, if it's properly used, can lower the incidence of death. We, of course, have the Caprini score. There's many roads to Rome. We picked this score because it's been used in most of the hospitals that we are dealing with. But anyway, when you do the score, you need to, in our mind, if you you need to double the dose for an increase in the score. Now, the guidelines talk about increasing the prophylaxis for a BMI of over 35, but what you have to understand is people who have BMIs of 35 or 40, what do they have? They have hypertensive induced cardiomyopathy, they have valvular disorders, they have pulmonary insufficiency, they have sleep apnea, they have diabetes with insulin. So it's a whole conundrum. And that's one of the things, of course, if you look at the Caprini score, we try to look at all of these things, but it's very important that these patients get a lot of prophylaxis early. And the other thing is, if for whatever reason you don't use the score on admission, my goodness, you've got to use it on discharge. And again, if you're used to using Improve plus D-dimer, Alex Spiropoulos, that has the best data using in the medical patients without the COVID-19 virus of a decrease by a third of significant VTE events after discharge using either rivaroxaban or betrixaban. Now, I'd like to stop and point out something that people never really talk about. And I would like to tell you how I look at immobility. It's those who can't walk 30 feet at one time with both legs. And we know from the subset of the Metanox trial, and that goes back to 1999, and Alpesh Amin published a beautiful subset analysis of this study. And in medical patients without prophylaxis, their incidence was cut in half if they could walk 30 feet. So that's the definition we're using. Now, those that are using a cane or a walker, that's fine. But if one foot isn't working, we know that if you don't weight bear on a leg, that there is no increase in blood flow in that leg. It's like having a paralyzed leg. And sitting up in a chair or walking short distance to the bathroom does not qualify as ambulation. And it really bothers me that in these that now that we're coming out with these extremely high quality ASH guidelines based on relative risk, chance of incidence of DVT, and they're very sophisticated in their analysis. But when they look at the charts, they only count no ambulation as people who are at bed rest, and that's nonsense. A lot of people that go to the bathroom or sit up in their chair are not ambulatory. So I had to get that off my chest. I'm sorry about that. And the same thing with casts, boots, or braces that inhibit the normal calf and foot muscle pumps. Now, we also decided that these patients with the COVID-19 need a serial blood test. And recently I saw a report that negates that we don't want to follow serial D-dimers. That to me is not really valid, because as those D-dimers go up, sometimes 8, 10, 12 times normal, you can't just sit there. You have to try to do something. And those patients we try to approach with more anticoagulation. We have to remember about kidney injury and using unfractionated heparin. And unfractionated heparin, by the way, as an aside, has been my secret weapon for all the years I practiced and ran a coagulation laboratory. The thousands of times we would go to the operating room with the surgeons, although I was a surgeon, and have a heparin drip because this was a high-risk patient. And if something happens and the patient starts to bleed, you shut the drip off. So it's a very important modality that you can use. We don't like DOACs during hospitalization. We don't have enough information on those. Stick with the heparin or the low molecular weight heparin if you're concerned about bleeding, and make sure that you're using mechanical prophylaxis. Now let's talk about ultrasounds. D-dimers, although they follow the severity of the disease and make a marker of worse outcomes, ultrasound screening, we believe, is unnecessary if the D-dimer is negative. High D-dimers should not be the sole indication for duplex scanning. Just because you don't have a clot in the groin doesn't mean that the patients are not subject to pulmonary embolus. We know that 60% of people with pulmonary emboli have negative leg scans, plus the fact that pulmonary thrombosis occurs in this disease. So the venous duplex ultrasound should be used similar to what you would do in a non-COVID-19 patient, and only if it's going to change the clinical care of the patient. Oftentimes those patients with real high D-dimers will be on full anticoagulation anyway. And the other thing is, I'm sorry about that, let me go back. If the patient does need a scan, you should use point of care ultrasound scanning with a portable device and hooked up to a phone or a little tablet, and not drag those machines around the hospital that are very difficult to clean. 2-point ultrasound is very important here because you're just trying to find out gross information, but very selectively. And here's our algorithm for inpatients with COVID-19, BMI, Caprini score, and D-dimer. If the score is less than 8, the BMI is less than 35, and the D-dimer is less than 3 times normal, we use the standard signs of standard low molecular weight heparin dose, which is probably 30 BID. It could be 40 once a day under certain circumstances. If the patient develops DVT signs and symptoms, then they can be screened if they have DVT therapeutic anticoagulation. If not, continue the prophylaxis. If, on the other hand, their BMI is over 35, Caprini score of over 8, D-dimer, particularly if they have heart failure. They should have double the anticoagulation dose at least, and if the D-dimer is 3 times normal or more, we're suggesting therapeutic anticoagulation. We're also suggesting that what I've seen since is a lot of patients who are in ICU, they're intubated, they're prone, and they have increasing oxygen requirements and tachycardia. Those patients we put on low molecular weight heparin. Now, everybody should take a careful look at this slide. You know, the more we don't know history, the more we have to repeat it. My brilliant fellow, Juan Arcelis, who, by the way, was very instrumental in making the Caprini score a reality, as were a number of other people that I'd like to acknowledge, but there's not time. 77% of people, and these are medical and surgical patients that were discharged from the hospital in the RIATE database, they developed a DVT, and 55% of them after prophylaxis was discontinued. Well, ladies and gentlemen, what do you think is going on with COVID-19? It's an increased layer on top of this. So these patients all should have discharge prophylaxis, and here's our algorithm for that. Patients with documented DVT, we continue the therapeutic anticoagulation. If the Caprini score is 8, the BMI of over 35, particularly if they have heart failure, particularly if they're not ambulatory, as our definition, D-dimer is less than 3 times normal, then they can go on a DOAC for 6 weeks or longer. And if the D-dimer is 3 times normal, then therapeutic heparin with a follow-up ultrasound in several weeks. And anybody we put on therapeutic heparin to see whether or not they have a demonstrable DVT, and then reassess at 3 months. I would like to remind you all, as much as I'm in love with the Caprini score, and I think it's the most thorough risk assessment, it's not the only road to Rome. And in particular, the wonderful data of Alex Spiropoulos and the Improve Plus D-dimer has to be taken into consideration, and that may be a good starting point for a lot of these patients, but most of them are going to need prophylaxis. And so this slide just shows, of course, if you have all of these, the coronavirus is one powerful element in thrombosis, but look at all of the other baggage that surrounds that the patient may bring to the table. And don't forget, there's an increased incidence of arterial thrombosis, DVT, PE, stroke, pulmonary thrombosis, primary pulmonary thrombosis, fatal pulmonary thrombotic events. Careful risk assessment is important. It should be doubled for high scores. Or if you use the improved D-dimer score, and prescribing discharge prophylaxis is critical. And remember, focused ultrasound. I'm sorry to rush through all of this, but I've got so much on my mind, and I'm so anxious to share it with everybody that I apologize for rushing through like a fire hose out of control. With that, I'd like to thank you all for your attention, and please visit my website, venusdisease.com, or my YouTube site, Venus Resource Center. Thank you very much for your attention.
Excellent. Thank you very much, Professor Caprini. That was fantastic start to the webinar. I will try to take some questions to you from attendee. The first question comes from Dr. Vladimir Klashid-Mendov. He said, according to Caprini score, healthy patient with only COVID-19 diagnosis may fall into a low-risk category that would not warrant VTE prophylaxis. What do you say to that, Professor Caprini?
Well, it's pretty hard if you already assign a patient of a risk score of 2 and they're over 40, that's 3. That although technically you may have some patients with lower scores, we recommend routine prophylaxis for all of those patients. And so in that sense, you might say there's a weakness in the score. You know, nobody ever said this was perfect. And and the other thing is, so here's another point for everybody to consider. And I often get run up against this, especially with the lawyers in wrongful death cases. And they will say, well, it's not in the guidelines. Well, let's say you have a patient and that patient has a fracture of the leg. Guidelines say no prophylaxis. You don't give them prophylaxis, they die. Now you have another patient just like it. Are you going to do the same thing and say that's God's will? Or are you going to say, you know, that was a bad outcome. I'm going to use my clinical judgment and experience to try to improve the outcome. That's where we come in to answer this question. Although, yes, that's technically true, clinical judgment and experience would dictate that we forego that because we know all of these patients are at such high risk and that the disease escalates so rapidly that you need to get a start on this. And so anyway, that's the answer.
Yes, it just came to my mind. Can you add to Caprini score COVID positive or negative as risk, and then it will be like an updated score in the pandemic that we can use?
Yes, so I've had that in the slides, and I know I talk so fast, and I apologize for that. But COVID diagnosis is good for 2. We say if they're symptomatic, it's 3, and then if they have a positive D-dimer, it's 5. And you can see that most patients that get hospitalized, they have hospitalized because they have symptoms. And so they're going to right away have a 3. If they're over 40, they're going to have a 4. If they're over 60, they're going to have a 5. If they're over 75, they're going to have a 6. So that starts us right off. If the BMI is over 25, you add that. They have leg swelling, you add that. So very quickly, it adds up. So.
Okay, fine. We got another question from Dr. Omar Ad-Dahlan. He said, thank you very much, Professor Caprini, for nice presentation. Can family history of thrombosis increase Caprini score in some way?
Now you've hit another sensitive button. A number of years ago, a decade ago almost, there was very compelling data, and a lot of it came out of Scandinavia. There was one study in 183,000 patients that were followed for 25 years. There is an increase of venous thromboembolism in 1st, 2nd, and 3rd degree relatives. It goes down with each degree. That's number 1. Number 2, other studies in the American Journal of Medicine in 2009 have shown that patients that have a family history of thrombosis, but they don't have a thrombosis, but they have baggage, that they may be up to 60 times more likely than the person without that family history to get a clot. It's all out there. There's slides on my website that indicate that, but please track family history in those relatives, and that automatically, that's a score of 3. And if there's also a known thrombophilic defect, that's a score of 6. And for the life of me, as wonderful as the Padua score is, as wonderful as the improved score is, and I'm not sure about the British score, the family history of thrombosis, they talk about known thrombophilia. Well, we don't test for thrombophilia these days, and that's relatively uncommon, but what's the history? And that's what I mean about never treating a stranger. If you don't know their family history, then they're a stranger, they're not your friend.
Okay, now we have 5 of the few hundred attendees raising their hand. I will take the first one, Professor Imad Hussein. He's Professor of Vascular Surgery Ain Shams University. He's well known for his quick questions. If Professor Imad, you can unmute yourself and ask your question to Professor Caprini. Professor Imad Hussein, can you open the mic?
Yes, sir. Am I being heard?
Yes, we can hear you now.
Yes, Professor Caprini, it's a great pleasure to see you live. It was one of my dreams, and I tell you right away, you have impacted our practice in the region and in the country. A great presentation. My question is, do we have enough current evidence to go with increasing doses of anticoagulation in COVID-19 positive patients who are being hospitalized for severe symptoms, especially if they are a Padua prediction score 4 or more?
Yeah, so first of all, I'd just like to interject here. I had a wonderful time in Dubai, and I've had a wonderful time around the world.
Of course.
One of the penances that I have to pay for my sins is not being able to shake all of your hands and to hug all of you.
Oh, I miss that.
People are beautiful, and there's beautiful people everywhere in the world, and especially in your region, I've had such wonderful experiences over the years. But yes, by all means, the more anticoagulation, the better. What's the downside? What's the downside?
Bleeding risk.
And here's the thing. So you're worried about increasing the dose? You can always use, if the patient's at high risk of bleeding, use a heparin drip. If anything happens, turn off the drip.
Okay.
But I think more heparin rather than less early. And don't forget about Oscar Ratnoff, and at least you will knock down factor 12 as a partial pathway. You're not going to control all the other things because of the cytokine storm, but you will knock down some of the contact activation features which actually superimpose themselves and make it worse. So remember contact activation. That's
okay. We'll take another question from the attendee. Dr. Joanne Chunga, please introduce yourself and ask your question. Joanne. It takes a few seconds for the mic to open. Okay. Joanne Chunga, I think probably from the name is from China. Yes, your mic should open soon. Okay, it seems we have a problem with the voice connection with Joanne. We'll take after that, Jaysir Tudka. Oh, Joanne, yes, there is a problem with the mic. We'll take the next, raise the hand. Jaysir Tudkar, your mic is on. You can speak, introduce yourself and ask your question.
Yeah. So thank you very much, doctor, for sharing your experience and the guidelines about COVID-19 handling surgeries. I have a question. For how long should we defer the elective surgery in a COVID positive patient?
So I'm sorry, what about the elective?
He said she said how long we defer the elective procedure in COVID positive pandemic. How long do we defer electives? Well,
that's probably an impossible, very, very important question, but it depends on how, if it's purely elective surgery, I would really wait until things settle down. And that may be a period of months, especially if it's a quality of life improving procedure. Now, certain procedures are not, and even though they're elective, they may be done for very important reasons. So I think it varies according to the procedure. We certainly need to test everybody prior to operating on them, and we hate to operate on somebody who is positive, especially if their D-dimer is elevated.
Okay, we'll take the last question from Professor Erika Mendoza from Germany, one of the most eminent vascular angiologists. Welcome, Erika. Your mic is on and you can ask your question to Professor Caprini. Okay,
I'm seeing Erica. I'm looking at the questions. She wants to know if scoring and anticoagulation at admission to hospital or also for ambulatory patients.
Yes. Yeah, the mic is on. She can, yeah.
Oh, okay, good. Yes.
Thank you, Joseph, for this wonderful presentation. Everybody enjoyed. Yes, I'm of course asking for ambulatory because you presented, I think, the data of when patient is admitted to hospital, but at least in Germany, lots of them are not in hospital if they are coughing and so on. And you know, I'm trying to go ahead with a study to compare heparin in prophylactic dose. Do your guidelines also are possible for ambulatory patients? This is the first question. And the second question, you talked about Fonaparinux. Is Fonaparinux also having this anti-inflammatory effect like low molecular weight? Thank you.
Wonderful questions. And, you know, I get heartsick for all of these countries when I hear you chime in. I've had many wonderful friends and times in Germany as well, and many important contributions from the Germans. So first of all, if a patient gets diagnosed with COVID-19, they should have also, this is an ambulatory patient now, so that presumably they've had some symptoms, and because of the symptoms, they get a test. So that automatically puts them in my arbitrary score right now. Automatically they have a 3, and then but then also all the baggage. So let's say the patient that if they're over 65, if they have other comorbidities, those ambulatory patients saddled now with symptomatic COVID and they're still not in the hospital, I would start them on prophylaxis right away. And there's a place, we don't have data in this, of course, and this has to be studied, but this would be a nice place. Now, if it were me, I'm so used to giving myself heparin shots and teaching them, I'd start low molecular weight heparin shots, but it would be very appropriate to use a DOAC, a direct oral anticoagulant for that. And that would be possible. So don't forget about that ambulatory patient, because in the mix, who are the patients that get sick and die? They're the ones in the nursing homes. They're the oldest people with the comorbidities. The young people are walking around. A lot of them get it. Most all of them are going to survive unless they have comorbidities. Now that's the other reason to do risk assessment, because you may have, I take care of a family and the young man is paralyzed. He has locked-in syndrome and he has a severe blood clot, but his mother, his sister, his brother, and his grandmother all have clots, and he's 22 years old. So if you have a young person that has that, especially the family history in the background, that person is at very high risk. Now on to fondaparinux. We know that heparin by itself is a chain of around 50 sugars, and it's cut down to 15 or 20 with low molecular weight heparins of various kinds, and that removes a lot of the extraneous non-clotting properties. But remember that fondaparinux is a very, very small molecule, and it's a wonderful drug. And yes, you can use it a lot, but you are going to lose a lot of the properties that you would get with heparin or low molecular weight heparin. Is that important? I have no idea.
Okay, thank you very much. That was great. I will take final question from Professor Eberhard from Germany. If you would like to ask your question to Caprini.
Yes, Joe, I have a question on COVID negative patients, which might be on an elevated risk in home office or in reduced mobility. So my question is, do we know anything about the risk elevation in those patients which are victims of COVID, but they are not themselves positive with the infection? Should we not do also prophylactic measures with non-medical prophylaxis, for instance, in those in home office, older patients who have other risk factors?
Good, very good question. So let's have a hypothetical. I have a wife who works in an essential industry, maybe a nurse. So she comes down with COVID-19, but doesn't need hospitalization and is quarantined. So she's going to live with me, coming back home. And now I'm the person, and I happen to be at risk. Well, of course, if it was somebody like me who's older, automatically I would start taking a low molecular weight heparin or a DOAC. But I think that the cases have to be individualized. The person that is living with the quarantined individual, in my opinion, needs to be scored. Score it with whatever score that you use, the British score, the Padua score, improve, or so forth. And if that patient comes up positive on the score, I would give them prophylactic anticoagulation, especially with a DOAC. And you know, what's the downside? And what's the downside if you don't do it and they get the infection and they happen to have had, let's say, a family history and you didn't pay much attention to that? Now they can get the rip-roaring disease, and you may have been able to prevent that with a prophylactic dose. Science, logic, emotion, and experience. That's what we need to use for all of our patients in all of these situations.
So the mic is back to Professor Sergio to continue the conversation. Please, Sergio.
Yeah, and I will take this chance of having all these experts headed by Joe for a question that very probably has no answer. In few weeks from now, hopefully we'll go back to elective procedures also on superficial venous system. And we know from the O'Donnell paper 2015 that the risk of thrombosis is below 1% with the thermal, with the sclerotherapy. But according to your experience in particular, Joe, and all the panelists and all the colleagues here today, do you think having a more potentially positive asymptomatic among our patients, we will have to consider one procedure rather than the other, for example, sclerotherapy rather than endovenous thermal, rather than non-thermal? For these patients, do you think, Joe, it's going to make a difference, the kind of procedure we will do, or we should not care about this?
Very complicated question. First of all, in those patients that you would test them if they're COVID positive, you wouldn't do it. That's number one. If they're COVID negative, then I would give them a traditional risk score. And the other thing is that we know from Wakefield has got some very good data, Andrea Obi and Wakefield in that group. And if you split the procedure, you use the lowest, in other words, don't combine, for example, endovenous ablation and also powered phlebectomy or multiple phlebectomies, trying to do everything at one time. If you do individual procedures, the risk is less. But I would use the same, we have a score, we use the score in those patients, but Wakefield has used the score. And if the score is over 8, then those patients need to get protection for a week. Now, that introduces another very sensitive point with me. We know over 30 years that the efficacy for the anticoagulation to prevent venous thrombosis is 5 to 7 and 10 days. And this idea to give a shot and that somehow protects the patient. In the United States, we know that's failed with the Surgical Care Improvement Project. One shot does nothing and several shots don't do anything. And the idea, and I'm still unsettled about the medical guidelines that say, well, when you go home from the hospital, you can stop your anticoagulation. That's why that curve with Arcellus showed was so high. You need a week of prophylaxis. If you're in the hospital for 1 or 2 days, you need 4 or 5 more days of prophylaxis. And the same thing, if you're under 8, you don't need anything after a vein ablation procedure. But if you're 8 or above, I would give somebody a week of prophylaxis. And then I would do a scan to make sure that there's no problem. And then if there isn't, stop the prophylaxis.
Joe, can I just ask a little bit more? Would you, in this time of COVID, potentially asymptomatic positive patients, increase the duration of compression after a procedure, for example, or the anticoagulation prophylaxis in general, or not?
Yeah, I've always had a bias with that. I had a lot of experience with pin stripping, and I always made the patients wear compression for 6 weeks. And again, the downside, there's very little downside as long as the compression is properly properly sized and is worn by the patient. You know, the British have done, and my dear friend Alan Davis and his colleagues, they've done, and Professor Whitley's on this call as well. You know, this stocking conundrum and all this money we're spending on stockings, but the stockings aren't fit properly in most of the patients. And because they're not fit properly, they're worthless. And they may even be worse than worthless. Now in the United States, we use these so-called TED stockings. And you know the difference between a regular size TED and a large size TED is they're longer. They're no wider at the thigh, at the calf, in the foot, where it's very important. So my hat's off to what the British are doing, but until there's better sizing and so forth, you know, without that, again, that's another sore point of mine. Sorry to go rambling on.
Thank you, Joe. Okay, so Omar, should I go on or do you want to moderate some more?
No, I think we took most of the questions. So the mic is back to you for the introduction of the next speaker, and that's it. So mic is back to you, Sergio.
So I'm in troubles again, because after I introduced Luciano Pavarotti, I have to introduce Maria Callas now, because of course, Jing Song Wang is very well known with a curriculum that speaks for itself. She's a professor in China, in particular at the Sun Yat-sen University, and she has been actually a pioneer also in the arterial ward, but she has been actually the first one doing several procedures in southern China. So once again, I will suggest everybody to have a look at the curriculum of the spectacular faculty we have today, but even more to try to get in touch with them personally as soon as possible, because I have had the pleasure of also meeting personally many times Jing Song, that indeed summed up his curriculum when she sent it to me, saying, just say that we are close friends, because it is indeed true. And that's a pleasure to see that big expertise goes also with big humanity and niceness. So I hope soon we'll be in China all together once again to enjoy the wonderful quality of science you have over there and also your nice attitude. And with this, I welcome your talk, Jing Song. Thank you so much. While we are waiting for the mic of Jing Song, she will be talking about the strategy for treating vascular emergencies during the COVID-19 pandemic in China. The mic is off, Jin-song. You have to unmute your mic.
So now.
Yes, good.
Can you hear me? Yes. Thank you, Sergio. And it's very honored to be with the world famous vascular surgeons and fellow biologists together tonight to share with the special situation of caused by COVID-19. COVID-19, we know it was broke out in December 2019, and it quickly result into the pandemic broke out in worldwide. And I'm so sorry for this, but this is the current situation, and there are so many patients now. And during the pandemic, because it's a strong contagious characteristics, frontline medical staff is at high risk for occupational exposure and infection. And therefore, preventing nosocomial infection is a particularly important and challenging task during this pandemic. Here's our data from China. Like we can see at the beginning of the outbreak in China, and there are many physicians who were infected by COVID-19 because of the shortage of PPE. And during this pandemic of COVID virus, and vascular emergency cases such as acute aortic dissection, ruptured aneurysm, and acute arterial embolism, and DVT, or other high mortality vascular disease, because we have a short rescue windows. So it is a very special situation for of challenging to deal with, because nosocomial infections are most likely to occur from contact during the patient transport and the management for this vascular emergencies. And to prevent frontline medical staff members from being infected, our hospital, the first affiliated hospital, Sun Yat-sen University at Guangzhou, our vascular centers, has used the National Diagnosis and Treatment Plan and the infection prevention and control protocols of our hospital in our operating center to devise various protection and control strategies regarding the management of vascular emergencies during this pandemic. And given that the pandemic has spread worldwide and many international colleagues deal now with similar highly challenging and dangerous scenarios, it's good, like in some countries it has decreased. I'm very pleased to share our guidelines and the strategies for everyone's benefit. And the general principle, I think is very important, like the hospital need to organize a very specialized medical task force group immediately after the infectious disease is announced. Here's the handbook of on management and prevention of COVID-19 from hospital, and we translated into English version, and our 8 team brought this to Seville to help the people there. And for the general principles, the first one is establish prevention and control protocol in operating center. It's very critical for vascular centers because it can reinforce and ensure the protection by medical personnel. And it also provides the protective strategies for patients pre and post-operatively. And it gives the regulation of isolated operating rooms, and with rehearsal, and that can limit the cause infection in the hospitals. And during the pandemics, blood availability for transfusion is often a very challenging situation because few people give the donation, but more patients need blood transfusion. And hospitals need to communicate closely with their local banks, blood banks, and keep track of blood available for planning operations. At the beginning of the pandemic in February, and our hospital only got like 7,000 milliliter of blood per day. So it's very limited for the patients who need major operations. And the hospital should initiate as many blood donations as possible and to get enough blood supply. And here's me to give the blood donation during the pandemic. And for the outpatient practice, to avoid cross infections and prevent the further spread of the epidemic, elective and non-urgent vascular operations like vascular varus closed veins should be delayed based on the current and predicted numbers of COVID-19 patients. Elective patients should only be performed when the numbers of COVID-19 patients is low. And here's our cases, our vascular in the patients in our vascular centers. Like we can see, so this blue is the aortic iliac disease, and this red is the lower limb operations, and this green is the visceral and carotid subclavian disease, and this purple is the DVT. And so we can see during the panic of during the pandemic of COVID-19 in February in the hospital, and this the numbers of the patients just decreased. But we are our hospital, because we have a very strict isolation policy, and so we recovered. You know, like in China, we recovered more rapidly than other countries for the spreading for the reopening. So from April, and our numbers of vascular disease just almost recovered as normal as in the past. And the screen and COVID screening and the triage, coupled with vascular image studies, should be performed expeditiously. Screening for COVID, including history and physical examination with temperature check, chest CT scanning, and for regional swab samples for nucleic acid test and point of care antibody test. Imaging relevant to the patient's vascular emergency should be completed. Nucleic acid requires an extended time, usually 4 to 6 hours, and it might produce incorrect or unreadable results from improperly retrieved samples. Point of care antibody test for COVID-19 may be quick, but it's limited in locations. It is not popular in China. We use the nucleic acid test more widely. Performing a plain chest CT reveals characteristics lung inflammation caused by COVID-19 infections. And this screen test results can immediately differentiate COVID-19 patients from those with other conditions and expedite treatment planning. If surgical intervention is required, minimal invasive endovascular interventions are preferred due to less blood loss, reduced likelihood of blood infection, and decrease the post-operative recovery time. If open surgery is necessary, staged procedures and alternative methods can be used to avoid major surgical operations that involve the major blood loss. Life-threatening conditions should be addressed first, with secondary operations performed only after limits on personal protective equipment and blood bank volume have been lifted. And the type of anesthesia is basically determined by the type of emergency vascular cases. Aortic surgery should be performed under intubation, and the lower limb surgery can be performed and local nerve block or intubation is necessary. And the training is very important. training medical personnel for COVID-19 related procedures and rules are so important because most doctors have limited knowledge and experience in the prevention and control of infectious disease. The details such as wearing proper personal protection, enforcing disinfection measures, and engaging in proper training are so vital to avoid nosocomial transmission. And this is me to train our doctors for with the knowledge of COVID-19, and this is how they to show how to do their hands sanitization, and our every faculties and staffs in our hospitals has been trained by different courses of COVID-19 prevention and control. And for the vascular emergency, the overall assessment and treatment principles including the two situations. One is the treatment of confirmed or suspected COVID-19 patients with acute vascular surgical disease, and patients with vascular emergencies with unstable vital signs caused by COVID-19 should be immediately separated and isolated. And a multidisciplinary team should quickly assess these patients. Under the level 3 protective standards, tracheal intubation is performed combined with other required resuscitation treatments. If possible, vascular treatments is performed after the patient is in stable condition. Suspected or confirmed COVID-19 patients with unstable vital signs caused by vascular emergencies should be resuscitated in an isolated area. A multidisciplinary team performs a rapid assessment of the risk and benefit ratio. If the benefit is greater than the risk, a surgical treatment plan is quickly formulated. The operations performed in an isolated DSA or hybrid operating room. After surgery, patients are transported to an isolation ward that actively treats COVID-19. If the risk is greater than the benefit, the patient should be isolated for conservative treatment following the same isolation procedures as above until his or her condition is stable enough for surgery. Patients who have unstable vital signs and cannot be screened should be treated as if they were confirmed COVID-19 patients. Testing can be conducted later if the patient is stabilized. And treatment of non-COVID-19 patients with acute vascular surgery disease should be treated for as usual following the process for diagnosing and treatment and treating vascular emergencies. And during emergency vascular surgeries, and our strategies for the prevention and control of COVID-19 are listed as below. First is preparation of isolation room, operating room. An isolated operating room should be under negative pressure. But if it is not available, and an operating room with separated air conditioning can serve as an alternative. And there should be limited numbers of staffs in the operating room. And the isolation signs marking the presence of possible harmful staff should be displayed outside the operating room door. The PPE involved in the operation should be streamlined. The number of the staff should be limited in the OR room. And all the supplies are fully prepared before the patient enters the room. All medical personnel all medical personnel should be equipped with the PPE according to the level 3 protection standardized. And for the patient transport, it is very important. And because the COVID patient could cause the hospital infection during the transport. So special routes designed by the hospital task force is very important. And routes should be cleared and have minimal human traffic before transportation into limited contact. And during the transport, and medical personnel should wear the level 3 personal protective equipment. And the patients must wear a mask. And if the condition is good, the patient could be transported in a negative pressure isolated chamber. And the equipment should be disinfected after each use with disinfectant containing 2,000 milligram per liter chlorine or 75% ethyl. And the elevator should be immediately closed and disinfected with ultraviolet light for 1 hour. And for the medical surgical personnel, they must put on surgical protective wear, and the intraoperative precautions should be alert very carefully. And this is our level 3 PPE equipment, and with including the gown, the goggle, and the shoe covers, and to avoid, this is the best equipment to avoid contamination from COVID-19. And during operation, the contamination of the environment should be avoided as possible. And if it's infected, and the disinfectant solution with 5,000 to 10,000 milligram per liter chlorine solution should be used immediately. And for after operation, and the patients, if the patient is intubated during the operation, and then we usually send the patient back to the isolated ICU ward to extubate at the isolated ICU ward. And the surgeons and the anesthesiologists, and while adhering the level 3 protective equipment during the patient transport to the isolation, the ICU ward. And after the operations, the surgical persons should throw their contaminated equipment in the isolated area before entering a locker room, and the personnel should shower and change their clothes before leaving. And if they are suspected contaminated, or they should go to quarantine for 14 days. And for the reusable surgical instruments after the operation, and they should follow by the procedures of disinfection, cleaning, or sterilizations if possible, and in the chlorine disinfectant. And for the pathological specimens, and pneumatic transport shouldn't be used at any point in this time. And the specimen should be well labeled with COVID-19 and transported from the negative pressure operating room along the designed pathway to the pathological department. And for the wasteful items, they should be well packed in a double layer of yellow medical waste bags with well labeled COVID-19. And the supply room is notified and immediately before the items are transported there for the treatment based on the particles of this special wasteful bags. And the final disinfection should be carried out, and when there are visible contaminants on the ground, walls, or other surface in the operating room, the contaminants are removed entirely from site surface before disinfected. And when there are no visible contaminants, the surface should still be wiped or rinsed with 2,000 milligram per liter colorant content in disinfectant, and then with clean clean with water after 30 minutes. And for the indoor air and the negative pressure laminate flows should be closed, and practical access pigmentation disinfectant should be performed. And the operating room post-disinfection must be closed at least 2 hours before reopen. Negative pressure laminate flows be opened for 30 minutes before operations rooms are cleaned. And after cleaning, the negative pressure laminate flow should remain open for 30 minutes. And after air is sterilized, in-room filters need to remove and treated according to the medical waste protocols to clean. And operating room can only be used after 2 sets of samples have resulted in a negative mark for contamination. And that's the general strategies for the operating rooms before or after the operations. And besides of that, the provision of personal protect equipment to patients and staff when needed is very critical. I believe every country faced to the shortage of PPE due to it is outbreak of an infectious disease. And but I think the government or third-party assistance to enhance PPE manufacturing is very vital to guarantee that a steady and reasonable amount of PPE is consistently available. Like in China, in our town, besides our country, before the outbreak of COVID-19, there was only one single PPE manufacturing company. But in 1 month, and they built up to 20 factories to produce PPE. So I think the government and the third-party assistance to make the PPE is very important for the medical persons and the patients. So in summary, and during the pandemic of the COVID-19 with the vascular emergencies, establishing detailed infection control and prevention protocols in all operating room is very important, and expediting testing procedures and the patients for a screen for COVID-19 is very vital. Utilizing case-specific treatment planning for vascular patients with COVID-19 and favor the minimal invasive methods, and establishing and reinforcing protective knowledge with medical personnel and training are very important to reduce the nosocomial infection. And this is based on hospital, medical, surgical, and protective protocols, along with the related management process that developed based on our hospital experience. There are inevitable deficiencies and omissions for the guidelines, and the criticisms and corrections and suggestions are always welcomed. Thank you for your attention.
Thank you very much, Professor Ginseng. That was fantastic. No wonder China have such very good numbers compared to other places. I really enjoyed your fascinating lecture and the elaboration of how we can going to start surgery in COVID-19 era. So let me divide. We're going to take one poll to take the opinion of the 1,000 surgeons. Here is the poll. If you are your COVID-19 patient is admitted in ICU, would you apply graduated medical compression stocking? You have three options. Either yes, stocking is sufficient, or yes, but only in conjunction with pneumatic pump, or three, never, and use only anticoagulation. Please submit your reply, and it will take about 15 to 20 seconds to analyze the result from the 1,000 attendee. After that, I will have a quick panel discussion, and then we'll take a few questions, and then we'll take another poll, and then we'll shift to Sergio after that. So when you have the result, Mr. Khalid, you can put it on the screen. And let me take the opportunity of such a great panelist with us. And let us speak first to Professor Eberhard from Germany. What you like to comment on Professor Ginseng lecture? Professor Eberhard, your mic is on.
Okay, I didn't see that. Yes, okay. I think this was a very good lecture showing that it is necessary to be very careful with these kind of operations in these times. And I think it's a very good strategy to minimize the infection rates. And I think also that China has shown that it can be very successful. However, the conditions in different countries are quite different. And not in all countries such a strict regime might be possible, but it's a good wish to do so.
Yes, thank you very much. You can see the result of the poll, which is quite interesting. 41% said yes, stocking is sufficient, and 46% said only in conjunction with pneumatic pump, and 13% said never. If I ask the same question to Professor Ginseng, which vote you will poll on?
I choose the first one.
Yes, I thought so. I thought the first one will be dominating, but it seems this information is not rapidly spread to other doctors. Let me take the opportunity, Professor Cabrini, do you like to comment on Professor Ginseng lecture? If you can unmute your mic.
Yes, thank you very much. That was an incredibly detailed and fantastic presentation showing just how careful one has to be, and also showing the results of what you can achieve with the proper procedures. And again, there's no mystery why the cases are low there in China with this kind of effort being put forward. And also I noticed it was very interesting that they went from one company to 20 companies within a month to get, that's incredible. So I think it's a testimony to the whole system, and I congratulate her, and also at this point I'd like to say hello to all of my Chinese colleagues.
Yes, they actually were able to build the hospital 1,000 bed, I think in 6 days or something like that.
Something like that.
Yes, let me take the opportunity of having Professor Mark Whiteley. Your comment on Professor Ginseng lecture, what do you like to add?
Thank you very much. I thought it was a lovely lecture, very, very detailed. What I find very interesting, especially after the fantastic lecture before that with Professor Caprini, is the interest I have really is what's the difference between the COVID-infected patient who has an aneurysm or something that's unrelated versus the patients that are COVID-related vascular problems. It seems to me from what we've heard so far, this seems to be a distal thrombosis. So it seems to be more of a, rather than pulmonary emboli and vascular emboli going somewhere, it seems to be a diffuse thrombosis at the capillary level, venous level, and arterial level. So therefore, this is almost different from the normal sort of vascular processes we see, which we have, you know, like a deep vein thrombosis that embolizes the lungs, or we have a thrombus in the heart that embolizes to a leg. This seems to be almost the end organ getting inflamed and thrombosing and then working its way back. Do you have a comment with the arterial cases you've seen? Do you think COVID is causing more arterial disease? And if so, is it a different pattern?
Yes, Professor Jensen.
So this is a question for me?
Yes, his question for you, yes.
Okay. So I mean, like actually in our hospital, there are very few COVID-19 patients. And I know, like, because you know, like the government asked the hospitals, a lot of hospitals to send the team, physician and nurse team to Wuhan to help, because there were so many patients there. And their feedback is like, I haven't heard like they have like for the patients like to be taken care by our team, there was no patients with arterial embolism. But I heard from like our colleagues in the local hospital, there was one arterial embolizations for patients with severe ischemia, like the patient underwent amputation finally. So I would say like arterial embolism was not as popular as the vein thrombosis in these patients, but it really happened, and it is not very often, and the outcome is very bad, because like, you know, although like during that pandemic, every procedure just delayed, because you need to screen the patient, and the physician actually, I mean, the physicians and the medical staff are kind of scared with like this situation, and they prepared very well. I mean, it takes longer time than the normal situations, and so I would say, and in our hospital actually, like, because we are short of the blood volume from the blood bank, and one patient with type A aortic dissection, and he couldn't get operated because there was lack of blood volume, and the patient died during the observation while waiting for the blood volume. So I would say like arterial embolism is not as many as vein thrombosis, but the prognosis was very bad during the pandemic.
Yeah. I can see a question from Professor Sergio. I know that you are very busy in the hospital, but you can ask a question to Professor Jensen.
Yes, it was just more like a brainstorming, Jin Song. Wonderful lectures, of course. We restructured a little bit over here the management of ulcer patients. So since this is a phlebology community mainly, I was wondering if you can give us some insights on how you eventually change the management of ulcer patients that are usually admitted for a daily basis in the hospital, and if you increase the self-management of these patients at home, how you perceive this in the future to be managed. So ulcer self-management topic.
Okay.
So you mean the vein ulcer, the patients who suffered from vein ulcer?
Yes. Yeah, since this is a venous community basically of this webinar, I was wondering if you can give us a perspective on how you change the management of these patients that usually come in the clinic for a weekly visit, and then now with the COVID around, we will have very probably to dilute in their visits. So that, for example, we significantly increased over here in Italy the self-management, using also products related to self-management and education of the patients in this.
Yeah, I mean, like, first I will like share with you one case with a female a female with DVT, and this lady actually, she's pretty young, is in her 20s, and she complains with a swollen leg before the Spring Festival. I mean, before the the big pandemic in China, and she went to the emergency room. She had the ultrasound screen, but the patient. So she went back she went back home before the result, the ultrasound come out, I think, and then the patient, the doctors in the emergency room didn't prescribe her any medication. And so she went back home and she said, oh, it's so scared. I mean, it's so risky to go to the hospital during this pandemic. So she stayed at home for more than 1 month. And then after the situation was getting better, and she came back to my clinics. And so I sent her to the ultrasound, and I prescribed her CT scanning for the lung. And because I suspected she must have the PE, because she didn't be administered on any anticoagulation. And then 1 week later, her mom came to me and said, show me the result of the pulmonary CT A scanning, and she is got PE, and she's with DVT. And so I just want to say that our patient is not as, I mean, it's not, the value is not like the patients in your country. And during that time, like patients is more scared with COVID-19 than other things. And so I don't see many vein ulcers during this pandemic. And the patients rather stay at home and to tolerate it because they think COVID-19 is more risky than the ulcers during this time. So but I mean, if my regiment, I mean, to treat this ulcer during this time, I would just run them on stocking for to compression, and because still during this time, when our patients, when we go to the when we admit the outpatients to the hospital, the patients still need to have their nucleoside exit test for COVID-19 and the plain CT scan, and both are negative, then they can go to the then they can be admitted to the hospital, which is very I mean, too much for the patients with only vein ulcers. So we do not admit many vein patients as usual as before the outbreak of a pandemic. I think they would say.
And Professor Ayman Fakhri, I can see that you are joining us from your hostel and you're very busy with your operating list. So do you like to comment on Jin Song lecture? And we'll go back to Caprini after that. Yes.
Yes, thank you very much. It was very nice and illustrative talk. Thank you. You did very well indeed. I like your strategy and putting the priorities in order. This was great, and showing the results of what you had did in your hospitals. It was great. Let me ask you, what's the prophylaxis measures you do for VTE prophylaxis?
Okay.
For VTE in our hospital?
Yes.
Yes.
In your hospital.
And we use low molecular heparin and rivaroxaban. These are the two most popular prophylaxis and the stocking in our hospital.
Excellent. I can see question from Professor Caprini, and then we'll go to Russia to Professor Kirill. Go ahead with your question, Professor Caprini.
Thank you very much. I would like to comment on Sergio's question because I identify with that with our wound clinic. We have a large number of wound patients, and these patients usually are seen on a weekly basis, and they get some debridement and rewrapping and so forth. And one of the changes because of this is that we have taught patients, and I also did this in the past, is to use a Velcro compression device. And it's interesting because the sponsors of this, SIGVARIS, have what I think is the absolute best model, because it has hooks and it doesn't have any Velcro, so it doesn't wear out. But even patients that are crippled can be taught to put this Velcro device on, any one of a number. There are 6 different companies. And this is a short stretch compression bandage, which is much, much more efficient than stockings. And it's very much easier to put on. So that we have, I would say that in your COVID patients, and because of the COVID pandemic, all those patients are treating with ulcers, I would go ahead and try to teach them to use Velcro compression devices of one sort or another. And then if they can't do that, advanced wrapping techniques. And one of the masters in the world is Giovanni Mosti. We can all learn from him. They show you many techniques. And even if the patients can be taught to use short stretch bandages, but the trouble with ulcers is that often stockings are used, and stockings are not enough because they don't provide short stretch compression.
Excellent. That's a very nice point about an advantage of one of the many products of SIGVARIS. So let me have the final comment from Russia, from Professor Kirill. Do you like to comment on Professor Jin Song's lecture? If you can open your mic, yes.
Thank you very much. I enjoyed the lecture. Unfortunately, I don't have the personal experience in managing surgical patients during the COVID outbreak, because all our hospitals are now just carrying on COVID patients. It's just the infection hospital. But what I learned during this month is that we should take a very big attention to the protection of medical staff from this infection, because in Russia we now have the statistics that we have the highest number of infection and even death in the medical staff who is providing the medical care to the patients, not only in the specific hospitals designed for the COVID infection, but also in other hospitals. And some hospitals are trying to be COVID-free, but we know that this step maybe false negative in about 30% of cases, and any urgent procedure may infect the medical staff. That's why it is very important to use the personal protection equipment and all the other measures that was presented nicely in the presentation of Dr. Jin Song.
Okay, thank you very much. So I will take 3 questions from attendees. There are 3 doctors who has raised their hands. And after that, we'll do the final poll. So let me ask Mr. Dirk, your mic is open. You can introduce yourself to Mrs. Jin Song, and then you can ask your question. Dr. Dirk. Okay, if you can unmute your mic. We'll give it 10 more seconds to see if you're unable to unmute. Okay, sorry about that. We can take Dr. Anas Abbas. Dr. Anas Abbas, unmute your mic, introduce yourself and ask your question. I would just advise attendee to test their mic before joining the webinar because some of the problem with the mic communication. Dr. Anas Abbas. Okay, again, unable to unmute. I'm sorry about that. We'll take, I think his name is written in Russian. So I cannot pronunciate it correctly, but we'll open his mic. And I hope this time it works. We'll give it 15 seconds to ask his question. Question from Russia. Okay. Okay. Well, we're unable, so instead I will take from the question and the answer written comment. One of the questions to you, Professor Jinsong, in the mechanism of anticoagulation, is the mechanism of anticoagulation is clear? I mean, is it sepsis inducing coagulopathy or primary by chylokines? So he's asking about Dr. Fadi Al-Husseini is asking about the pathogenesis of thrombosis in COVID-19. Is it mainly inflammatory element or mainly endotheliitis? And what is the pathway so we can trigger it correctly?
Well, I think like Dr. Cabrina has talked in his slides, I think it's because of inflammation. I mean, yes. Very special inflammation. So like this COVID-19 is different from other viruses like regular influenza. It is caused more severe inflammation compared with other viruses. And I heard from my colleague in Wuhan, like it's like when the patient feel like dyspnea, like short of breath, and its lung has been more like 50% white, and it means the inflammation is very severe. So I think inflammation is the main mechanism from the thrombosis.
Okay, we'll take one question from Dr. Omar Ad-Dahlan. He said, thank you very much for a great lecture. Do you recommend the screening of COVID-19 as a routine for emergency and the elective cases? So anyone going to hospital, do you do COVID screening, or do you think this is a good policy?
Yeah, I think so. Yeah, in China, this is the policy. For every patient who go to the emergency room, I mean, if they want to admit it to the hospital, I mean, if they have the emergency like a situation, they need to go to they need to be admitted to the hospital. Every patient needs to have their screening test for nucleic acid, and that prevents nosocomial infection. I mean, it is indeed, and because like at the beginning, and in one local hospital, they didn't screen the patient. There were 2 patients with COVID-19 who were admitted to the hospital, and the hospital was closed for 2 weeks. So I think this is good.
Excellent. I will take a question from Professor Isam Osman. He's one of the famous vascular surgeons from United Kingdom working in Saudi Arabia. He's actually the advisor of the Minister of Health on COVID-19. Welcome, Isam. You can ask your question.
Good afternoon. Good afternoon. Thank you, everybody, for a wonderful webinar. I have 2 questions, really. The first is to Dr. Jinsong. Thank you very much. I found your talk very, very informative and informs a lot of the discussions we're having here. Can I ask, when you return to elective activity, which I understand from your presentation, April, what were the conditions that had to prevail before you did that? Did you look at epidemiological factors? Did you look at bed occupancy in the hospital? And so on and so forth? And did you screen everybody? Were you screening staff before they were working in the area for elective surgery? So what was a mechanism for return to normal elective surgery? And before she answered that, Dr. Mohammed, I wanted to ask the panel, in relevance to your poll, have they read the recent publication of a very well-conducted randomized controlled trial in the BMJ looking at graduated compression stockings as an adjuvant to thromboprophylaxis in elective surgery, which showed that stockings add no extra benefit to thromboprophylaxis? Maybe Mark Whiteley would like to comment on that in particular.
Okay, so let us take the first part. What is the preparation we should do to start our elective work? In your advice, Professor Jinsong?
So you mean for the medical staffs returning back to the hospital?
Yes.
Yeah, we didn't screen the medical staffs for returning the hospital, and we are.
No, sorry, if I could. Sorry, maybe I've not made myself clear. You stopped all elective vascular surgery for a period of time, and then you decided to restart again. So what were you looking for that said it's okay to start again? in terms of the surgery and the hospital?
If we never stop the emergency operation during the pandemic. However, like it's like it depends on the pandemic. Like we take the regular patients. I think as that's the early. It's in China. We have very short time for the outbreak especially in Guangzhou, maybe in 2 weeks. Like at the beginning of March, and we like gradually open the clinics and admit the patients. It depends on the cases every day, like new cases every day in the city. I mean, it's different in China because we have very strict isolation policy, so it is quicker. I mean, than Western countries.
Yeah. Okay, that's a good answer and good reply. And I know you have a debating point about the last reading that we have done in BMJ. You know, there is multiple analysis to the effectiveness of graduated compression stocking, especially in the era of post-COVID with thrombosis. And you will get in favor and against. I think most of the published paper recommendation for graduated compression stocking that it will decrease the element of post-thrombotic complications. And also we know that the COVID-19 is mainly a thrombogenic disease. So I think the benefit outweigh the harm. So let me take the opportunity to have the final poll before we shift to Professor Sergio for the presentation of the last lecture. Now the second poll is COVID-19 endothelial illness involving systemic vascular tree. Do you believe that applying medical compression stocking can play a role in curing, reducing, or preventing endothelial dysfunction on COVID-19? Yes, always with anticoagulation, probably yes, and will help improve result, but not for curing. No, I don't think so. Please, if you can put your result on the second poll, and then the result will show us in about 20 seconds. And let me, in this 20 seconds, take opinion of Mr. Professor Mark Whiteley about the last published paper in BMJ about effectiveness of graduated compression stocking. Do you like to comment, Whiteley?
Not really, no, on that. I think Sergio is far better, or Professor Caprini, to talk about prophylaxis and stockings. That's their areas.
Okay, so we'll take Professor Caprini, then Professor Eberhard, and back to Sergio. Professor Caprini, your valuable comment.
Well, thank you very much. We know again from history that patients that have a low incidence of venous thrombosis, giving them anticoagulation doesn't further lower their risk of thrombosis. And the same thing, I think, with stockings. There's several things about stockings. Number one is that the stockings have to be sized properly, and we don't know from that study what was and wasn't sized properly. Number two, we don't know the risks to the patient. You put those on a low-risk patient, they're not going to do a thing. You put them on a very high-risk patient, they may help a little bit. And I agree with the overall evaluation that you said that in these patients that have many risk factors and have COVID and are symptomatic, the downside is zero as long as they're fitted properly. And I would always use them in conjunction with intermittent pneumatic compression and anticoagulation. And so we need more information. And I can understand why the article is written, because they're spending millions of dollars of precious resources in the United Kingdom for stockings, and they're putting them on everybody. And so, you know, so that in that sense, the paper is very valuable, because you can't just do that. But we need more information to find out what specific group might be of benefit. And again, I hate to come back to this all the time, but it's risk assessment, risk assessment, risk assessment. Thank you.
Excellent comment. And Professor Eberhard, eager to hear your comment.
I want to make 2 points. The first point is on the nomenclature, because graduate compression stockings, that is what was used, but in reality, it's 18mm Hg thromboprophylactic stockings, which is completely different from medical compression stockings we use in ambulatory patients. This is something, you know, we cannot compare, we cannot put in one pot. So that means thromboprophylaxis in outpatients is never done with thromboprophylactic stockings with 18 millimeters Hg. So that's just one point for the nomenclature. The other point is that the incidence of deep venous thrombosis in both groups was very low, below 2%. So if you have such a low incidence of deep venous thrombosis in your population, both groups with low molecular weight heparin very effective, it's very hard to have any additional benefit, and you would need a much bigger study in these percentages to see any significant difference between compression and no compression. So it's a nice study, but I think it doesn't really answer the question of the value of compression stockings in thromboprophylaxis.
Yeah, thanks very much, Professor Eberhard. And the result, you can see the result of the second poll speak for itself. And the mic is back to you, Professor Sergio.
Well, if I have to comment on the BMJ after Joe and after Eberhard, it's like singing after Pavarotti and Carreras, so it's pretty difficult as well. But I would say that there is a nice publication showing the importance of the interface pressure. It was published on Journal of Biomechanics in 2013. And you can have even the same surface pressure having 50% variation of the inner pressure. And there was another publication showing the variability of the interface pressure with the different sizing. So if we don't start putting in the papers like we publish in a document that we now publish on phlebology after the winter meeting, always the interface pressure, we don't know if we are talking about oranges or apples. So that's a fundamental thing to say, I would say. So thank you, Joe. And so if I have to move forward, I think, right, Umar? Are we moving to the third speaker? Yes? Yes. So this is just slightly easier than before, because after having introduced Pavarotti and Maria Caldas, I have to introduce Andrea Bocelli. That is just a little bit newer in the arena, but still has a wonderful curriculum. He's a professor from Russia, Pirogov University, and he has also a PhD thesis on thromboembolism prevention. You will have the chance also in this case to see the wonderful job he's doing, and I'm sure we will keep on seeing him more and more. But more than that, again, I would suggest always to meet these great professionals personally. I had the pleasure of being in Moscow with Kirilli and to explore what he called nicely a terra incognita, which means an unknown land, which is the name of his meeting there. That is really spectacular in the active involvement from the stage directly to the operating room. So I'm sure we will enjoy greatly his talk, and I see that indeed he's a smart one with the presentation already ready. So Kirill, impress us, as I'm sure you will do. Thank you.
Thank you very much, Sergio. I'm really appreciated for this invitation to take part in this brilliant meeting on the very important topic. And of course, the coronavirus disconnected us, and we have no opportunity to meet at any real conferences. But however, there is new topics that we can discuss during such wonderful online meetings. And of course, this is my disclosure. And you know that my country, Russia, has taken just recently has taken a second place of the prevalence of the coronavirus, and now it's on the third place. But however, we have not very high mortality rate. I'm not sure that it is the proper statistics, but however, our mortality rate is about 1%. I'm not sure what is the reason for such good results, but however, the statistics is so. And of course, in Russia, we have some educational programs, and one of them is our program. It's called the School of Thrombosis, and Professor Eberhard Rabe visited us 2 years ago and took a part in our educational program. And just a week ago, we had also an online meeting, and we discussed this problem. And when we prepared to this meeting, we reviewed some papers, some published data on this problem. And now I would like to present you the results of this review. It's focused on the current guidelines that were published up to the 22 of May. I would like to start with the incidence of venous thromboembolism in the patients with COVID infection, and we found 11 studies with just a little bit more than 1,500 participants, and most of these patients in the studies use the low molecular heparins in prophylactic, intermediate, or therapeutic doses. And as you can see, the incidence of DVT in the general ward was about 13%, and the pulmonary embolism about 8%. And in the intensive care unit, it was rather high. The pulmonary embolism occurred in about 80% of all patients. Of course, these figures are much higher than the previously published for the intensive care unit patients and the medically ill patients in the absence of prophylaxis. But however, these figures are obtained at the background of prophylaxis with low molecular heparin. So yes, we know for today that it is a very strong coagulopathy with the thrombotic surface with a thrombotic profile in these patients. And I would add some new information about, in addition to the lecturer, Professor Caprini, who told that this pulmonary embolism is not a Rayleigh's embolism, it's some kind of pulmonary artery thrombosis. And this is the summary of the morphological studies in the diseased patients. And you can see that the macroscopic thrombus that could be interpreted like the real pulmonary embolism, it was found only in 10% of patients, and 80% of patients had the evidence of the thrombosis of the small branches in the pulmonary artery and the capillaries. So it was called like the pulmonary intravascular coagulopathy. So for today, it's discussed as the main mechanism of the death of the deterioration in these patients with the severe coronavirus infection. And of course, the reason for the anticoagulation in these patients, they're obvious. On the one side, we want to correct this coagulopathy, especially in the pulmonary artery and capillaries. And we need to do it to improve the microcirculation, to prevent the acute respiratory distress syndrome, and of course, to prevent disseminated intravascular coagulation syndrome, which is the end of this septic inflammatory condition. And on the other hand, we need to prevent the thrombus in the limbs, the venous thrombus in the limbs, to avoid the pulmonary embolism that can deteriorate as well the respiratory status and lead to the hemodynamic collapse and the deterioration of gas exchange. And of course, we should take into account that this big number of patients suffering from the pulmonary artery thrombosis, they need to be followed up, and they need to be evaluated after 3-6 months after this event, because we actually do not know the long-term consequences of this thrombosis. Will these patients develop the chronic thromboembolic pulmonary hypertension or not? This is a very important question. So to answer, to reveal the current status, the current guidelines, what different professional societies are recommended to manage for the management of this coagulopathy, we identified 11 guidelines and we revised them according to the different points, the different issues. And you can see this, the list of these guidelines, and the search was limited by the English language, and I'm sorry if some other guidelines did not came in our list, but that is all that we were able to identify by the May of 22. And this is the references on these guidelines. So there were different questions about the management of patients with coronavirus. And the first question is the risk stratification for the venous thromboembolism. And 6 of 11 guidelines supported risk stratification, and only one guideline didn't support. It was the Anticoagulation Forum, and they stated that all patients who were admitted to the hospital should receive low molecular heparins in prophylactic doses, independently to their individual risk. So there was it was their position. And the risk assessment model that was mentioned in these guidelines are Padua score, Caprini score, and improved score. So the PADO score is well known, and according to this score, all the hospitalized patients will fulfill the criteria for the pharmacological prophylaxis because they will have the acute infection and the reduced mobility. Professor Caprini already presented the Caprini score and a modified version of Caprini score, but if we will take into account just the classical version of 2005, in this situation we can find the serious lung disease, which is the coronavirus infection. It is a score of 1, and the medical patient currently at the bed rest, it is the score of 1. So 2 scores, it's always the patient will receive if they will be hospitalized with coronavirus. And of course, there's some kind of acquired thrombophilia, these abnormalities that we can find in patients with the coronavirus and can be interpreted like the acquired thrombophilia. So according to this risk assessment model, also most of the patients will fulfill the criteria for the pharmacological prophylaxis. But what about the improved score? In this situation, we can't find the any evidence for pharmacological prophylaxis for all admitted to the hospital patients because there is no any references to the acute infection, to the acute respiratory distress syndrome. Only admission to the intensive care unit and increased age is valued for 1 point. And however, there is a modification, the improved score with the D-dimer, and it takes in account also the increase of D-dimer and allows us to increase the risk and to provide the pharmacological prophylaxis. However, this risk assessment model looks not very good for the assessment in patients who are admitted for treatment of coronavirus. And there is one publication which analyzes the risk of venous thromboembolism and the bleeding risk according to the PADO score and improved score. As you can see, not many patients fulfill the criteria. The high risk for VTE had only 17% of patients, and high risk for bleeding only 7% of patients. But however, all the VTE events and all the bleeding events, they were registered only in patients at high risk of VTE and high risk of bleeding. So this risk assessment model, maybe it is not very sensitive, but at least this paper shows that it should work in such kind of patient. So what about the prophylactic doses of anticoagulation, especially low molecular heparins? In this issue, all the guidelines suggest that low molecular heparins should be administered to all patients. It could be given to all inpatients, or it could be given according to the VTE risk. At least prophylactic doses of low molecular heparins should be administered to all patients without increased risk. This is the last 6 guidelines. They suggest to distinguish dose of low molecular heparin according to the individual VTE risk. And the basis for this recommendation, it was published by the International Society of Thrombosis and Hemostasis. They were the first who published these recommendations, and they suggested low molecular heparins to be administered in all patients who do not have contraindications, and contraindications is just the acute bleeding and low platelets, less than 25,000. That's the only contraindication. And the basis for this recommendation was the paper from China. They reviewed about 500 patients, and about 100 received prophylactic heparins, and there was no difference in the total mortality at 28 days of observation, but there was a significant decrease of mortality in patients with sepsis-induced coagulopathy and in patients with a critically elevated D-dimer. It was D-dimer over than 6 times over the upper threshold. And you can see that it was a really very intensive reduction of the risk in such kind of patient. That's why the International Society of Thrombosis and Hemostasis, they supported the benefits of prophylactic low molecular heparins in patients admitted to the hospital with COVID infection. And this is their recommendation. So they recommend just not to monitor the coagulation status and to look for the D-dimer, prothrombin time, platelet count, and fibrinogen in hospitalized patients, but also they suggest to look the same laboratory parameters in patients, in outpatients, and if they have increase of the dimer or prolonged prothrombin time or decreased platelet number or fibrinogen level, in this situation, they suggest to identify such patients as a high risk of development of disseminated intravascular coagulation syndrome, and even if they clinically not very severe, they had not severe disease according to the classical classical clinical classification, they recommend to admit such patients to the hospital because they are at high risk of coagulopathy and disseminated intravascular coagulation. What about the increased doses of anticoagulation? This is the main issue and very important issue, and I saw a lot of questions about it in our web chat, in our question section, and there is a very big inconsistency between the guidelines. As you can see, about 50 to 50%, half of guidelines recommend increasing of doses to intermediate ones, and the other one do not support such increase, and it could be performed only inside the randomized clinical trials. So 5 guidelines which support such decision, they suggest to increase the dose in patients with the individually high risk. For example, as Professor Caprini showed, the recommendation of the American Venous Forum, patients with Caprini score of 9 and more could receive the increased doses of the low molecular heparin. The patients who are admitted to the intensive care unit due to the critical illness, and the patients who have the increased D-dimer level. It may be increased not very high, and it may be very high increase in the D-dimer level. And 2 guidelines do not mention at all the increased levels, increased doses of the low molecular heparins. And what about the therapeutic doses of low molecular heparin? It is the most important question, because I know that in many countries and even in Russia, there is a practice to increase the doses up to the therapeutic ones. And even in Russia, we have some strange approaches especially in the intensive care unit, to increase the doses over the therapeutic ones. So according to the monitoring of coagulation by thromboelastography or by the fibrinogen level or something like this, so the patient are receiving twice therapeutic dose, for example, they increase twicely. And what about this point of view? The 4 guidelines support therapeutic doses in patients without confirmed venous thromboembolism, and 6 guidelines suggest against such using of therapeutic anticoagulation. Those which suggest therapeutic doses, they suggest to do it according to the D-dimer level, and if a patient has a suspected VT, you suspect VT in this patient, but you cannot confirm it. For example, if it is a patient on the mechanical ventilation, and you can perform the CTPA scan for this reason. What are the basis for the increase of doses of low molecular heparin? Some of these guidelines are based on this meta-analysis of the patients with acute respiratory distress syndrome, and it showed the improved survival in patients with acute, non-specific acute respiratory distress syndrome when they received the low molecular weight heparins, and this was more common and more significant for the increased doses of low molecular weight heparin compared to the lower doses. You can see that there is a really great increase in survival, about 70 and 60%. And there is another paper from the Journal of Thrombosis and Hemostasis, which is usually referred when the authors try to support their decision to increase the doses of therapeutic anticoagulation. So in this cohort, it was a small cohort of 16 patients who had very high hypercoagulation according to the viscoelasticity testing of the blood. And author tried to improve their coagulation status by the increasing doses of low molecular heparins, by the transfusion of the antithrombin 3 concentrates, and adding the clopidogrel. So there was a question about the antiplatelet drugs in the treatment of severe form of COVID infection. And they had a good result. They were able to reduce this coagulopathy, but however, there was no any impact on the survival of this patient. Half of the patients died despite the authors achieved good coagulation status. So we cannot be sure that this increased the therapeutic doses of low molecular heparins will impact on the survival in such patients. That is the main argument in the guidelines that do not support the therapeutic doses. And another recent study from the New York, from the Mount Sinai Hospital, which showed the benefits of the therapeutic anticoagulation. I suppose you know it. It was about 3,000 of patients, and about 400 of them received the therapeutic anticoagulation, and there was no any difference in mortality rate among the total population, but among the patients on the mechanical ventilation, there was a great benefit and reduction of the risk by 53%. And here you can find the survival curves in the total population and in the patients on mechanical ventilation. And what about these studies? There is a very clear immortal time bias. So the anticoagulation was initiated with a median of 2 days and interquartile range of from 0 to 5 days. So that means that about 75% of all patients, they received anticoagulation during the 5 days. So they should be alive during these 5 days. And in the control group, the patients who did not receive anticoagulation, they died during this period. And you can see in this part of the diagram the great divergence between the survival curves. But however, after the 5 days, the curves are parallel. So that means that there was no effect of the anticoagulation. That's why for today there is no any clear decision, should we increase the dose of anticoagulation in patients with a severe and critical form of coronavirus infection. And there is some comments to increase the doses. For example, this comment to the interim guideline of the Society of Thrombosis and Hemostasis. And the authors suggest that such coagulopathy that we can see in patients with coronavirus, it's some kind of disseminated intravascular coagulation with a thrombotic phenotype, and this kind of disturbance of coagulation should be treated with increased doses of heparins. Also, the high levels of fibrinogen also could be observed in such kind of patients, and we know that high level of fibrinogen can lead to the resistance to the heparins, and also resistance to the prophylactic doses of the heparins, and then can increase the risk of thrombosis. And at the end, so high prevalence of microcirculatory thrombosis in the patients who died because of COVID infection, it suggests that the microcirculatory thrombosis may be the leading reason for the death, and that's why even there is suggestion to use the thrombolysis, the TPA, to in critically ill patients who do not respond to the adequate mechanical ventilation. But however, there is another point of view. It's interestingly that it is a paper from Italy who were fighting with the coronavirus for a long time with a very high prevalence and a very high mortality rate. And however, the doctors suggest again the increasing doses of low molecular heparin because they think that it is a thrombotic microangiopathy, and the mechanisms of this disease, they are not the same as the deep vein thrombosis and the pulmonary embolisms. That's why the standard doses, the standard prophylactic doses of the low molecular heparin, they may be enough to prevent deep vein thrombosis. And of course, in combination with the elastic compression stockings, they may be enough to prevent deep vein thrombosis, but to treat the thrombotic microangiopathy in the pulmonary vessels. They may be not sufficient, and moreover, we know that from the autopsy studies, we know there is a very high prevalence of hemorrhagic complication, like hemorrhages inside the alveolus, the hemorrhages in the interalveolar septa. So in this situation, increasing doses of low molecular heparins or heparins, it can lead to the deterioration of this hemorrhagic complication in the lungs, and of course it may not be it may not increase the survival of such kind of patients. That's why this author suggests that not increasing doses of heparins may be a need for these patients, but we need to look to another drugs as what the equation to the antiplatelet drugs, to the drugs that affect the Willebrand factor, or the complement, and some other pathological mechanisms that underlie the thrombotic microangiopathy, but not just increased doses of the heparins. So this is the general consideration of the guidelines, and you can see there is a high inconsistency in it. So there is no opinion to support or not to support the increased doses of low molecular heparins. And what about the mechanical prophylaxis? In this point of view, 5 guidelines support mechanical prophylaxis, and 6 guidelines do not support mechanical prophylaxis at all. This is really unexpected, and I don't know why so. 5 guidelines supported mechanical prophylaxis if anticoagulation is contraindicated, and 2 supported the additional mechanical prophylaxis like intermittent pneumatic compression in critically ill patients and immobilized patients. And of course, this is unexpected because we know the reviews, the meta-analysis, of course, this is the previous meta-analysis which does not take into account the new data from the BMG that was published. But however, we know that elastic compression can decrease the risk of venous thromboembolism, deep vein thrombosis, and pulmonary embolism in hospitalized patients, in surgical patients and medical patients as well. So it is a very big data that supports the using of mechanical compression and elastic compression stocking in such kind of patients. And of course, we know the intermittent pneumatic compression, which can reduce the risk of DVT and PE, and it is more effective than elastic compression alone, and it may be as effective as pharmacological prophylaxis. That's why it's usually suggested as an alternative to the pharmacological prophylaxis if the patient has a bleeding or low platelet level. In this situation, the IPC device may be the only choice to prevent DVT and PE in such a situation. And of course, the pharmacomechanical approach, when we combine the mechanical prophylaxis and the pharmacological prophylaxis, it gives us additional benefits. It allows to reduce DVT and PE, and if we compare to the pharmacological prophylaxis alone, it does not increase the risk of bleeding. And we have a study of the combination of all these methods together, IPC device and anti-embolic stockings and low molecular heparin. It was done in surgical patients to prevent the postoperative DVT and PE. And we included in the study patients at a rarely increased risk. So they had 11 and more Caprin scores. And in this situation, this combination, this pharmacomechanical approach demonstrated the very good results and decreased the risk of postoperative VT. Maybe this approach, according to the assessment of Caprini score and taking in account and applying the combined prophylaxis in patients with 11 and more Caprini score, may be beneficial for these COVID patients who are at really extremely high risk for postoperative VT. But however, there is no data in such a population of the patient. What about the extended prophylaxis? There was also some questions on this issue, and the 5 of 11 guidelines, they support the extended prophylaxis after discharge, and 2 do not support this approach. But however, they do not recommend routinely use of extended prophylaxis, but they suggest that it could be used in patients with individually high risk for VT and individually low risk of bleeding. And among those that support this prophylaxis, one suggests extended prophylaxis in all discharged patients. It was the Italian Society of Hematologists, and the four of them support only in the individual high risk of VT and individual low risk of bleeding. So in generally, they recommend the duration of prophylaxis for 35-40 days. So it was like in the studies Magellan Apex, which evaluated the efficacy of the direct oral anticoagulants in the medically ill patients. They suggest to use low molecular heparins, for example, enoxaparin or rivaroxaban or betrixaban, and also they suggest that we should select the patients who are close to the inclusion criteria for the relevant studies. I want to remember you that in Magellan and EPIC study, one of the inclusion criteria was the increased D-dimer. So these patients with COVID infection with increased D-dimer, they usually fulfill the criteria, the inclusion criteria of the Magellan and EPIC study. So they are very close to this population, and we can suggest the benefits of this extended prophylaxis in patients after discharge with rivaroxaban and betrixaban. What about the diagnosis of the venous thromboembolism? The two guidelines supported the liberal diagnosis. So that means that if you do not see the clinical signs of the DVT OP, but there is a very high level of D-dimer, or we can see the rapid increase of the D-dimer during the follow-up, in this situation, we can make some medical imaging to confirm or exclude the venous thromboembolism. However, 4 of 11 guidelines do not recommend the routine use of the D-dimer follow-up, and one guideline had no clear position on this issue. What about the clinical suspicion for the venous thromboembolism? 3 guidelines represent the clinical criteria which can be used for implementing some additional testing like CTPA in patients with severe coronavirus infection. They are hypoxemia disproportional to the known respiratory pathologies, or acute unexplained right ventricular dysfunction, or hemoptysis, unexplained tachycardia, or acute deterioration upon moving of the patient. So if we see such symptoms in the patient, we should suggest the pulmonary embolism and try to perform the CTPA. But however, in the real clinical practice, it is not always possible to perform CTPA in such severe patients. Also, there are some evidence of the D-dimer, the predictability of the D-dimer to the revealing of the deep vein thrombosis, or confirming deep vein thrombosis or pulmonary embolism in COVID patients. And there are 2 studies from the China and 1 study from the Europe, and all of them show that the threshold of about 1,500, between 1,500 to 2,000, they have the high sensitivity and specificity to reveal the pulmonary embolism or a deep vein thrombosis in such kind of patients. So this may be the additional marker that we can use to suspect the VT. However, we should be careful, because we know that the D-dimer thresholds in the Chinese population and the European population are different. That's why there may be some inconsistency in this interpretation. And 4 of 11 guidelines suggest the empiric therapeutic anticoagulation in patients with suspected VT. For example, if we see the high level of D-dimer and we suspect the pulmonary embolism or deep vein thrombosis, and we cannot perform the scanning, we can give to the patient therapeutic anticoagulation, not to treat coronavirus infection, not to prevent the venous thromboembolism, but to treat the suspected venous thromboembolism according to the laboratory finding. And these from these 4 guidelines, 3 suggest the delayed imaging. So after you started the therapeutic anticoagulation, you should make some imaging tests to find out if there is actually a deep vein thrombosis or pulmonary embolism. And 1 guideline suggests that if you decided suspected pulmonary embolism thromboembolismic patient, you should give him therapeutic anticoagulation for 3 months without any additional testing. So you have already made your decision, and nothing should make you to change it. And for example, this is the guidelines from Netherlands, and they suggest the liberal diagnostic of the venous thromboembolism according to the D-dimer level. You can see that if it is higher than 1,000 or 2,000, you should follow the D-dimer, and if it's rising up, you may perform some imaging test or prescribe to the patient the therapeutic anticoagulation. And it's more important that if patient has at the admission D-dimer of 2,000 and more, in this situation, you can suspect the venous thromboembolism at the admission and try to confirm it, or you may give to the patient the therapeutic anticoagulation without confirmation of this diagnosis. What about the switching of oral anticoagulants to parenteral anticoagulants? This is also a very common issue in all guidelines, and most of them suggest switching of oral anticoagulants to the low molecular weight heparins, especially in patients who were hospitalized and admitted to the intensive care unit. And if the patient is treated at home, in this situation, it is also they also suggest to switch vitamin K antagonisms to the direct oral anticoagulants if the patient is eligible, and this is the general considerations. So in most cases, the vitamin K antagonists should be switched to the direct oral anticoagulants, but however, there are some contraindications. You know, it's mechanical heart valves, it's valvular atrial fibrillation, it's antiphospholipid syndrome, it's severe renal impairment, and breastfeeding. And you should take into account the drug-drug interaction. It is very important because some antiviral therapy has an interaction with the direct oral anticoagulants. And if the patient who is on chronic anticoagulation admitted to the hospital, especially in the intensive care unit, in this situation, you should switch it to the low molecular heparin or even unfractioned heparin as intravenous continuous infusion. And the drug-drug interaction with the antiviral therapy you can find from this website. It is a Liverpool drug-drug interaction study group, and they regularly update the data. As you can see, there is a interaction between the direct oral anticoagulants and atazanavir and lopinavir and ritonavir, but there is no interaction with remdesivir, so it could be used in parallel with the direct oral anticoagulants. And at the end, what about the outpatients? Minority of the guidelines pay any attention to the outpatients, to the prophylaxis of venous thromboembolism in patients who were not admitted to the hospital, and 2 of them support the risk assessment in these patients. And for the risk assessment, they suggest to use individual risk factors, not Padua score, Caprini score, improved score, adjust individual factors like reduced mobility, increased body mass index, previous VTE events, active cancer. And 2 of them suggest the pharmacological prophylaxis in patients who are at low risk of bleeding. And 1 guideline does not support pharmacological prophylaxis in outpatients. And I would like to stress your attention in this issue that it is not the treatment of the coronavirus infection. It is not the treatment of the pulmonary intravascular coagulopathy. It's just the preventing of venous thromboembolism. It's another issue. It's another indication to use the prophylactic anticoagulation, because now, especially in Russia, we have a very big inconsistency in the prescription of different antithrombotic drugs in outpatients who are treating for the coronavirus. We can find them direct oral anticoagulants, low molecular heparins, we can find dipyridamole, we can find sulodexide, a lot of drugs which doctors are tried to use to improve the outcomes of the coronavirus. And for today, we have no any data that outpatients are at higher risk of VTE, and we do not any data that these thrombotic treatment can improve the outcomes in the outpatients. It is very important to know. And I would like to conclude that the prevalence of VT in patients admitted to the hospital with COVID is unexpectedly high, and the prophylactic anticoagulation, according to the all revised guidelines, should be administered to all patients. What about the increased doses of low molecular heparin could be increased in obese patients, in patients with individually high risk, but therapeutic anticoagulation is not usually supported by the current guidelines outside the randomized clinical trials. Unexpectedly, the mechanical prophylaxis is underestimated without objective reasons, and pharmacomechanical prophylaxis may be suggested to all ICU patients and individuals with the highest VT risk, for example, the Caprini score of 11 and more. And the extended prophylaxis after discharge might be suggested for patients with increased risk of VT and low risk of bleeding. The D-dimer may be followed and used as a criteria for the diagnosis of venous thromboembolism. And if you have the high suspicion for the presence of venous thromboembolism and you cannot perform the appropriate verification of the diagnosis, some guidelines suggest to start therapeutic anticoagulation. And of course, for in-hospital patients, the heparins, low molecular heparin and unfractionated heparin is preferred during the treatment. But however, the standard duration of treatment in patients with verified VT is 3 months. And after discharge, most of the guidelines suggest that the switching of the heparins to the direct oral anticoagulants, which are more comfortable for such kind of patients. And what is important, we need to remember about the chronic thromboembolic pulmonary hypertension and to assess the patients 3 or 6 months after their VT event for this complication. And if we see some decreased tolerance to physical activity or some dyspnea in this situation, it is better to continue anticoagulation and to refer the patient to the specific center which is dealing with a chronic post-embolic thrombotic hypertension, pulmonary hypertension. And the primary VT prophylaxis is not suggested in all patients, but it may be a benefit for the patients, for the selected patients who have the individual risk factors for the VT. Thank you very much for your attention, and I would like with great pleasure to discuss this issue if you have any questions.
Thank you very much, Kirill, for such excellent elaboration with a huge amount of information. And thank you very much. I'm delighted to have heard it. And let me take the panelist opinion. I can see Professor Jin Song raise her hand. Do you like to add a comment? You need to unmute.
Yeah, it's a very detailed information of our prophylaxis and treatment of in and out patients with COVID-19. And I have a question that, so like in China, it is that the NOx, like rivaroxaban, there's no evidence to use to prophylax for the patient with COVID-19. So what do you think? I mean, like, why is low molecular heparin is the best one currently? I mean, for some patients with 83 enzyme deficiency, if they are, I mean, we do not screen them, but if the patient with 83 enzyme deficiency and the heparin, I mean, it doesn't work. So what do you think? Why low molecular heparin is the best, is the first choice for patient with COVID-19?
Thank you very much. Yeah, thank you. Yes, I agree that, and most of the guidelines agree that the heparins are the best choice for the hospitalized patients because, as Professor Caprini previously said, there is not only the anticoagulation activity, and for today we have a big speculation about the antiviral activity of the heparins, that they can reduce the application and migration of the virus into the cells. It was shown for the previous SARS infection, but it may be the same for the COVID infection. We don't know really for this. And of course, the heparins have the antidote, so they could be controlled very well, and if patient needs some kind of thrombolysis or some kind of surgical intervention, you can use it very easily. Just use a protamine sulfate, or if it is intravenous infusion, you just can stop the intravenous infusion of unfractionated heparin and make an intervention. According to all guidelines, heparins are preferable for the inpatients. What about the dogs? Actually, in Russia, we have also no indication for the using of dogs as primary prophylaxis in medically ill patients. So these drugs are indicated only after the orthopedic procedures. That's why for our country, that's also off-label, but in the United States, the rivaroxaban and butrixaban, they indicated for this extended prophylaxis after discharge in medically ill patients, and that's why guidelines recommend to use it. But however, in our country as well, sometimes it's better to give to the patient oral drug after discharge and make sure that he will take it than prescribe him low molecular heparins injection and he will not use it.
Okay, I can see Professor Caprini want to add a comment. If you can unmute Professor Caprini and let us hear from your wisdom and your experience.
Yeah, first of all, brilliant lecture by a brilliant young man that I recognized his brilliance about 15 minutes after I first met him a number of years ago. Fantastic lecture. And I'd just like to highlight three things. The first thing was he emphasized the importance of using the mechanical methods in the highest risk patients. And I think that's really important. And the other thing that is important is that he also discussed, and we need to remember this, it's not only increasing, or let's put it this way, just because you can't achieve a change in death rate, perhaps, from increasing the anticoagulant dose, more likely than not likely, you're going to improve outcomes in people that survive, number one. And number two is it's got to be added to the other agents, the antiviral agents, the anti-inflammatory agents, even corticosteroids and so forth. And so I think that was nicely pointed out. And then the final thing is that after looking at all this and knowing what's in the medical literature and what has been published in the improved scores, for example, why all the guidelines don't recommend outpatient prophylaxis? Because it's been shown in medical patients, if they have increased risk, to give them outpatient prophylaxis. So now we take patients that are not medical patients that automatically have an escalation of their risk because of the virus. How in the world would you not treat those patients after they go home? I don't understand that, but a lot of things I don't understand. Brilliant lecture.
Excellent, excellent. Let me take the view from Professor Eberhard from Germany. Do you like to have a comment or a question to Professor Krell?
Yes, congratulations for this lecture, also for me. And I agree with Joe that it is not understandable that if you look to outpatients, that we reduce prophylaxis in outpatients compared to inpatients or in-hospital patients. Because even the outpatients, and you have to look to the infection group, which has maybe a lot of additional risk factors. Many of those are of old age, many of those have additional diseases, and there is I cannot understand why we should not do any kind of prophylaxis, at least non-medical prophylaxis, mechanical prophylaxis we can do in those patients. But that is not done, it's not recommended in the guidelines. So that is something I'm really not understanding. The reason may be that the groups which are caring for those patients are not very familiar with mechanical prophylaxis. And they don't know so much about that, but they are more familiar with drug treatment and drug prophylaxis. And this may be a discussion also for the future. And as I mentioned before, even those patients which are not COVID positive, but stay at home, sitting at home for hours and hours with a reduced mobility, may have an increased risk for deep venous thrombosis, for instance, not for pulmonary endothelial dysfunction, but for deep venous thrombosis. And this is also a group we have to care more for prophylaxis for deep venous thrombosis. It's not mentioned in any of the guidelines.
Yeah. Dr. Krill?
Oh, thank you very much, Professor Raba. I absolutely agree. The most guidelines were prepared by the societies of thrombosis, by hematology. So these specialists who have less experience in the mechanical prophylaxis, less experience in the using of elastic compression stockings. Maybe this is the reason that such a very simple approach is not represented in most of them. And for the outpatients, COVID negative or COVID positive who are isolated at home, of course, I absolutely agree that the mechanical prophylaxis, the elastic compression may provide some benefits. Not in the, I just want again to repeat and to stress attention. I do not believe that such approach can improve the outcomes of the infection, can increase the chance to cure the disease and to prevent the progression to more severe forms in the outpatients. But I agree that this reducing mobility in such kind of patients is a risk factors for the venous thromboembolism, and the using of elastic compression stockings in those immobile patients can reduce the risk of venous thromboembolism. But this is not the part of the COVID disease. It is a complication of the COVID disease.
Okay, and Professor Whiteley, do you like to add a comment or a question?
Thank you very much. I have two questions really that are related. The first is we've heard a lot, both last night and also today, we've heard a lot about the thrombotic effects of COVID. Do we have a clear number as a sort of percentage, how many people are dying because of thrombotic causes compared to any other causes such as sepsis or anything else? You know, are we talking 20%, 50%, even 100%? I've seen some of the post-mortem data, but you know, what is our view now as to the importance of that? And then secondly, as it clearly is such a major factor, and we can see the pattern of the thrombosis is not the same as we normally see in sick patients or patients who are having surgical procedures, should we be having a modified Caprini score or a modified Padua score for COVID?
Thank you very much.
Yes, please, Carol.
Thank you very much, Professor Whitley. Yeah, what about the current numbers? They are unavailable because the number of autopsies, they are low. And for today, when we analyze the data, it's about only 100 autopsies that were published. In one publication with a case of 12 died patients, they found the big thrombosis in the pulmonary artery and interpreted it the cause of the death in 1/3 of the patients. So 4 of 12 patients died during the pulmonary embolism. But however, in other cases, they not always saw the big thrombus in the big branches, in the general branches of the pulmonary arteries. But about 80% of all patients, in 80% of all patients, they saw small thrombus. So if we're, and the reason of the death, of course, it is respiratory insufficiency and cardiac insufficiency. So this microvascular thrombosis may be the reason of the death. So we can suggest now that about 80% of the patient, at least 80% of the patient, they are dying because, or maybe in association with this microcirculatory thrombosis. And it is really very important. And now we do not know how to prevent it and how to improve the results. And please repeat your second question.
So as the pattern, therefore, is not the usual sort of embolization, but it's a pulmonary or end organ thrombosis, should we be looking, with all the thousands and thousands of patient data we have now, should we be back calculating and having a COVID modification of these score systems?
Yeah. I see Professor Caprini has a comment on this, and as far as I know, that for today, no of these risk assessment model were verified in patients with a COVID infection, and now in our COVID hospitals we are working on the Caprini score, and I hope in a few weeks we will have some data on the verification of the traditional Caprini score 2005, and now Professor Caprini showed the modified version, and of course we will take it in account and compare the classical version and the modified version, and maybe we will have some insight on this issue.
Professor Caprini.
I think that's a wonderful idea, and again, corona positive 1 point, positive with symptoms 2 points, or I mean corona positive 2 points. If they're symptomatic, make it 3, and if they have an elevated D-dimer, age adjusted, make it 5. I'd love to see that, and I think that needs to be done, and it'll be very valuable information. We're trying to do it here, but the Russian studies so far have been so wonderful. You really know how to get it done and accumulate data, so I'm very much looking forward to what you find.
Okay, let me take the opinion of Professor Ayman Fakhri. Do you like to have a comment or a question to Professor Krill?
Yeah, of course. Thank you, Omar. Thank you very much. It was a very nice talk. But I would like to highlight your point. It is a case of disseminated coagulopathy, not pure venous disease. And I want to ask you, me and many other fellows all over the world saw many cases of arterial thrombosis in COVID patients. Do you think it is a coincidence, or the disease itself has a different mechanism? Because if we agree this is a different mechanism, it is not a pure venous embolic disease, we have to put other drugs, we have to put antiplatelets, we have to study it more. I want your comment. Is it a pure venous disease, or it is another pathology?
Professor Krill?
Thank you very much. Yes, of course, there is very different theories on the pathogenesis of this COVID coagulopathy, and one of the most appreciated it is the thrombotic microangiopathy, and also we know that the thrombotic microangiopathy, it's due to the activation of platelets, and so we know the role of megakaryocytes in the lungs. They can interact with the virus, and the virus can activate them and promote the production of the already activated platelets, which can affect as well as pulmonary artery and peripheral arteries and anything else. But however, this is not the only mechanism. There are a lot of other mechanisms, like Professor Caprini told, the thromboinflammation, the endothelial lesion. So we know that the virus can move into the endothelium through the ACE2 receptors and can produce the lesion of the endothelium. And recently, just a few days ago, there was a very nice publication in the New England Journal of Medicine with morphological studies. They evaluated the endothelium in the pulmonary artery with electron microscopy and find the very intensive lesion of the endothelium with the broken of its membrane and very intensive proliferative response with the angiogenesis. So it is very interesting. That's why this direct viral invasion into the endothelium, which can be found not only in the lungs, not only in the pulmonary capillaries, but outside in kidneys, in heart, in liver, in intestine, in different organs, it already was reported. That's why, and one more thing, it is the antiphospholipid antibodies, which can occur in patients. In about 80–90% of all critically ill patients with COVID infections, they have the antiphospholipid antibodies. So all these mechanisms together with the activated platelets, with antiphospholipid antibodies, they can produce the arterial thrombosis as well as venous thrombosis. So my opinion that it is reasonable to use some antiplatelet drugs in such kind of patient, but of course it needs to be studied. It needs to be studied.
Let me take a question from Professor Isam Osman. He is the advisor to Minister of Health in Saudi Arabia on COVID-19 issue. Welcome, Isam, on board. We will unmute your question so you can speak. I think we lost the connection with Isam. I think we lost the connection. Okay, thank you very much for a very nice discussion. Let me put the final poll before we give the mic to my dearest Professor Sergio. The poll number 3, your COVID-19 patient is discharged from hospital. Would you keep the patient on medical compression stocking for VTE and PTS prophylaxis? If yes, for how long? No, don't need it at all. Yes, 8 to 12 weeks. Yes, more than 12 weeks. If you can submit your answer, and let me take this few seconds opportunity to ask Professor Krell. You mentioned in your guidelines that they are contradicting. If the guidelines is relying on the same evidence-proved multi-randomized study, why should they come to a different conclusion? And if this so, why you don't make a task, let us say task 4, to unify the guideline all over the world? What do you think, Krell?
Thank you very much. I think, yes, there is a very big need to make some compilation of these guidelines and to produce something general for the whole world. But now what about the compression stocking after discharge? Personally, I do not know the studies that assessed the anti-embolic stockings after discharge and their influence on the incidence of postoperative thromboembolism or thromboembolism in medically ill patients. But I believe that if the patient is immobile after the discharge, of course, elastic compression stockings may have some benefits and to reduce the venous thromboembolism. But as Professor Caprini told, the ambulation, the walking is the most important issue. The patient ambulated well and is working well. Personally, I do not think that compression stockings can influence this inflammation, this endothelial dysfunction in the absence of chronic venous disease. If patient has absence chronic disease, chronic venous disease, in this situation, of course, he needs compression stockings, and during this immobilization, during this isolation, the compression stockings are very indicated to him. But if there is no chronic venous disease and the patient is mobile in this situation, I do not think that it provides some additional benefits. This is my opinion, and I don't know the evidence for this.
Yeah. We got the result of the third poll, and as I can see, 72% of the 1,000 attendee from Facebook and Zoom platform, they mentioned they will give a stocking for 8 to 12 weeks, which is fascinating. So thank you very much, and the mic is back to you, Professor Sergio.
Well, thank you so much, and I will take the few minutes to make some comments and questions. The first question actually is Kirili about the endothelial aspect you were mentioning, and in particular the glycocalyx. There are like substances acting on the glycocalyx that we usually use in the venous ward that have been demonstrated to be useful both on the arterial side and also on the venous side. For example, sudocexide. Do you think that in our venous patients now we should start thinking about these substances a little bit more, or do you think they could not play a role inside these new mechanisms you are assisting at?
Thank you very much, Sergio. As for my opinion, this sudocexide may be the best drug in outpatients with non-severe COVID infection because we know that hyperinoids have the anti-inflammatory activity and they protect from the venous thrombosis. And what is most important particularly in Russia, we cannot, legally, we cannot prescribe the direct oral anticoagulants because they are not indicated for primary prophylaxis in medically ill patients. But we can prescribe sulfixide because it is indicated for the patients, for example, in Russia, it seems like thrombopathy. So we can indicate it because the patient has thrombopathy, for example, he has the diabetes mellitus or arterial hypertension or some atherosclerosis, and he's infected with COVID infection. And in this situation, we have an opportunity to legally prescribe the sulfixide. It is a very important issue because only dipyridamole and sulfixide could be used in this situation legally. That's why my opinion that it may be useful, but however, we do not have any trials, we do not have any data that it could be beneficial to prevention of venous thromboembolism, or it could be beneficial to reducing the risk of the deterioration of this disease. This is my opinion.
And this is a question for all the three experts we have today with us as speakers. Are you aware of data crossover in terms of thromboembolism and different races, looking also at the tendency of the different races to have thrombosis? I don't know if this is something that could be useful to look at in the near future to understand better that the pathophysiology of COVID-19. What do you think about different races' impact of COVID and related thrombosis? Did you get the question? Should I?
You asked me?
Yeah, it is for you,
and for
Song and Joe.
Okay. Yeah. So what about the race difference? Of course, we know that in Chinese population, the risk for venous thromboembolism is low because they have the lower prevalence of the thrombophilia. That's why. But however, when we see the numbers, the figures from the papers that are coming from China, we have very high. So they found, for example, 25% of deep vein thrombosis in the intensive care unit. So it's absolutely higher than the previous data that was associated not with COVID infection, but for example, with other patients from intensive care unit. It was twice lower, about 12%, 15%. So of course, this genetics plays a role and makes some impact on the incidence of complication and incidence of venous thromboembolism. But however, the relative value, the relative increase, I suggest that it is similar. So in European population, we have the high level of venous thromboembolism. So we will have the higher absolute numbers, but the value of increase of relative risk, I suppose, will be the same like in the Chinese population.
Joe, do you agree with this? I was curious on your opinion.
Yes, I think that there are more similarities than differences. And without repeating everything that Kirill said, I think that that the other thing is that the individual factors are different. You have the genetics, you have the lifestyles, you have people that are based on their diets. So there are various things, but in general, there are more similarities than differences. But it is important to take these things into consideration. So in answer to your question, the single most important thing to do is to continue to assess risk, both with the current risk assessment models and improving those models and improving risk assessment. You know, as I've been around the world, the more people are pretty similar, really. There's more similarities than there are differences. Just they talk different, they have different cultures and that type of thing, but they're pretty much the same.
Jin-Sung, do you have a comment?
Yeah, I agree with both of them. But I want just to add one point. Is like, I mean, we should like control reduce the severity cases of COVID patients. I think if the patient developed into the severity phase of the COVID infection, and there's, the incidence of thrombosis is similar among the races. I think one of the most successful factor in China is we cut off the transmission pathway. So, and we give their oxygen supply as early as possible. So our a lower number of patients developed into severe phase compared with the Western countries. Like we sent a lot of medical staffs to Wuhan, and we expect that they would come back in July or June, but they came back earlier at the end of April. And I think the most important thing is we are collecting the patients, or potentially infected patients in our like we call it Fangchang Hospital, and so we can observe which patients could develop into severity, and then we transfer it into the hospital with more better supplies to treat them earlier. And I think our frontline medical staff said early oxygen supply is very important. That can reduce, the possibility of the patients get developed into the severity phase. I do believe this thrombolysis occurred more frequently in the patients with severity phase. If we can control lower the number of the severity patients, we can reduce the VTE incidence in COVID patients.
Thank you so much. So since I see that the time is almost over, we will drag some conclusion. I think it was really interesting, Omar, what you said about the guidelines. As you know, we have been working quite hard together with many colleagues and friends who are here. I'm mute. No, okay.
Yes.
That have been involved with us with the WIN Foundation last January with the winter document, talking about, can you hear me?
Yes, I can hear you. Yes. Yes.
And we indeed pointed out the data regarding similarities and controversies in global guidelines. So it is absolutely a need of a common effort in delivering homogeneous data. Yeah. In this, I want to say that there is a nice paper back 2002 talking about intermittent pneumatic compression that you were mentioning, Kirill, that was showing actually how just 1 patient out of 5 in the ICU was enjoying a properly used IPC, meaning that they had the IPC on, but it was not put on properly. Like Joe was saying, for example, the importance of the sizing of compression. So these data are tendentially biased. So I think it's fundamental that we gather together for proper homogeneous data, at the same time having global guidelines, the difficulty of the different nation aspects for which we'll have always, of course, to combine appendixes fitting in the different nations. Gathering together, I would also like to take this chance to deeply thank all the colleagues who are here involved today with this webinar, and also all the ones who will be involved with us starting from next Saturday in what is a common effort of a not-for-profit initiatives we are developing always with the WIN Foundation, because Lancet Journal published recently the impact of COVID, not just on the clinical aspect as we have seen now, but also on the health aspect of the general population because of the starvation following the lockdown policies, particularly in the poorest population. So I'd like to take this chance to once again deeply thank all of the attendees of this wonderful initiative of today, to deeply thank SIGVARIS that I appreciate in choosing a topic that is it is actually directly related to compression, but not stressing out so much of the topic of compression, because I think that indeed their learning is supported in a 360-degree way. So I really appreciate the top quality level of these webinars. No need to say the honor and pleasure of having friends and huge colleagues like George in Song and Kirill speaking. And of course, the pleasure of sharing this webinar with, I would say, the best host in the world, because you are like really well trained as host of webinars now, Omar. So it's really a pleasure of being here with you. So I would say thanks again, everybody. I think the take-home message is that we have to collect homogeneous data and stay pretty ready in changing our indications, since we are in a changing world, unfortunately, in these days, hopefully in a better change future. Thank you, everybody.
Thank you, everyone. Bye-bye.